Yes, തുടങ്ങി.
Good morning to all of you. Respected President KSOS, General Secretary Dr. Mahesh, Scientific Chairman Dr. Rajiv sir, our Chief Instructor Dr. Praveen, our moderator Dr. Kiran, and all the audience who's come in this morning, Monday morning, to attend this CME. This is a different CME. The Kerala Journal of Ophthalmology has been doing some programs from the past 1 year for research, and Dr. Praveen has been our mentor and guide for that. But this is not just research. It is utilizing that research into our daily clinical practice. So how do we do that? Now, Dr. Praveen is a renowned national and international public health expert. And he has been on the board of many journals, international journals, but he's interested more in training. So he's come around to see the rural parts of India and find out the problems there and try and develop clinical guidelines with the best possible evidence. And this he's very successfully done with the Radiological Society of India, where he has actually developed guidelines for monitoring pregnant females with Doppler. And that program called the Samrakshan program has actually now attained national status. It is a very successful program. They have monitored, they have tutored radiologists all over India. And those guidelines, the algorithms which he and his team have developed have helped a lot of pregnant ladies and in-risk patients to be detected early so that they could be saved. So it is a similar thing that we are trying out here. So this is basically an introduction to how to bring out the best practices. It is not an easy job because it has to be good evidence. It has to be easy so that people can understand, and it has to be prevalent. Everything should be available. So it is not a very prevalent practice in India, but in the Western countries like UK and USA, they are using guidelines. So this introduction hopefully will tell our KSOS members what all this is about and maybe encourage them to be in the forefront of this program, in this kind of developing guidelines, so that we can also start some leadership programs. So over to, can I invite or can I request Dr. Babu Kushamar, President KSOS, to please speak a few words and inaugurate the session.
Dear Dr. Mahesh, Dr. Rajiv Sukumaran, Dr. Sudha, Dr. Praveen Nirmalan, Dr. Kiran Gopalakrishnan, respected seniors, dear delegates. Let me congratulate this initiative by KJO-Scientific Committee of KSOS. We are good clinicians, brilliant academicians, and manage our patients excellently. But sharing our clinical insights and the guidelines we should format our practice are the matters we are left behind. When I took charge as president of KSOS, I had communication with Dr. Sudha, editor KJO, on her future plan. She had full of ideas on how to improve KJO and empower our members to write and publish in a journal. Accordingly, she had 4 initiatives to shoulder with KSOS agenda. First one is basic training in writing and publishing articles. Till now, this program had completed with 3 batches and 100 participants. Second project of editorial training of 1 year has completed 2 months out of 1 year duration. The realization of her third event is getting inaugurated today. Clinical practice guidelines, what should clinicians know? This is a topic of far-reaching importance. We should know how the medical fraternity defines, correlates, and manage updates in our frontiers. This is a topic of importance to members of KSOS and more for present and future office bearers of KSOS. We are fortunate to have Dr. Praveen Nirmalan, who is an ophthalmologist, as well as one who had done fellowship in public health ophthalmology from Johns Hopkins School of Public Health, USA. The 4th project of KJO is a session in Drishti 2021. With much satisfaction and happiness, I am inaugurating today's KJO-Scientific Committee joint venture. Thank you, Dr. Sudha and Dr. Rajiv, for this path-breaking initiative.
Dr. Mahesh, please.
Respected President, Dr. Babu sir, Scientific Committee Chairman, Dr. Rajiv, Dr. Sudha, Dr. Praveen, and senior members. I am very happy to see this is, I think, for the first time in Kerala KSOS history that such a thing is being done. Thanks to COVID, so that we are able to do this online. This clinical practice guidelines, actually, I didn't know what clinical practice guidelines was. So I was going through the materials and then understood what is guidelines. Anyway, this is a very good initiative. So all the members will be benefited by this. I wish this grand success, and so that we can replicate these things in our practice. So I wish all this program all success. Thank you.
Dr. Rajiv, sir, please.
Yeah, thank you, Dr. Sudha. Respected President Babu sir. As you all know, Babu sir wanted this observership program to be conducted for the general ophthalmologist in major hospitals in Kerala. But due to this COVID, this program could not be conducted. And so we have come out with webinars, few webinars already being conducted on as a part of this presidential project. And Giridhar Eye Hospital also had done a few weeks back. So KJO came out with this beautiful idea of clinical practice guidelines, which is the brain child of Dr. Sudha. And she wanted the help from the scientific committee to organize this. I've given her all the technical support, not the scientific part of it. Okay, whatever she wanted, I have helped her. Hope this program will be useful to all of you. And we have an excellent person like Dr. Praveen here to deliver the talk. Thank you so much. I wish the program all the very best.
Thank you. Over to Dr. Kiran Gopalakrishnan, who will be now introducing our instructor as well as taking over and moderating the session.
Thank you, madam. It's my pleasure and honor to introduce Dr. Praveen Nirmalan. So he's completed his graduate studies from Thrissur Medical College and subsequently pursued his post-graduation from the famed Aravind Eye Care System and did his training as a vitreoretinal surgeon in Mumbai. And he first forayed into public health and public health ophthalmology by first completing a master's and subsequently a fellowship at the renowned Johns Hopkins in Baltimore. And since then, he has been a part of various national and international public health programs. He has been a very famed public health ophthalmology researcher at Aravind and LBPI. And most ophthalmologists would know the two comprehensive eye surveys conducted in South India in the past Andhra Pradesh IDC study, and he has been an integral part of the team that conducted these public health surveys. A lot of us would have read articles regarding this. And he has been mentoring clinical researchers in obstetrics and gynecology, neonatology, radiology, in various specialties. He has publications across a wide range of subspecialties in ophthalmology as well, in corneal ulcers, in diabetic retinopathy, in glaucoma, cataract, and has published population surveys and related materials, not only in India, but also in Nepal, in Papua New Guinea, East Timor. It's a very, very wide field of work. He has mentored over 200 MD, DNB, PhD students, and he is currently a research mentor at Amma Healthcare Research Gurukul. So we're very honored to have Dr. Praveen Nirmalan with us. We are looking forward to hearing from you. I welcome Dr. Praveen Nirmalan to start his workshop. Thank you.
Okay. Thank you, Dr. Babu, Dr. Rajiv, Dr. Sudha, Dr. Mahesh, Dr. Kiran. I must say that let me just share my screen, but I must say that I was quite impressed with the dedication that Sudha has shown to bring research into the forefront of clinical practice in Kerala. And I think that's an important part to do, because I really don't see a distinction between clinical practice and research. And that's been the way that I have looked at it. The person that Dr. Kiran introduced, at some point of time, if you would let me know where he is, I would really like to meet that guy. He seems to have done a lot of work. And I really look forward to meeting him at some point of time and trying to figure out whether that person still exists or not. But coming to the topic of today. Now, before we start any webinar, we have to do our customary, I hope I am not audible and I hope I am not visible introduction. So I hope that's happening. I'll talk today about clinical practice guidelines. And this is going to be a basic introduction to clinical practice guidelines. The basic might be a little bit comprehensive, but stay the course. And a lot of these things are things that you would have heard of during your clinical practice, you would have heard of during your clinical career, things that you instinctively and intuitively understand. There would be some technical jargon that are associated with these terms, but stay the course on that. Now, you are what your deep driving desire is, and as your desire is, so is your will. And as your will is, so is your deed. And as your deed is, so is your destiny. And this comes from the Brihadaranyaka Upanishad, which is one of the largest, it is the largest Upanishad that is available. Brihadaranyaka, Aranyaka forest, Brihadaranyaka, large forest. And it's the largest Upanishad that's possible. So I start with this quote to subtly and not so subtly tell you that what you take out of this workshop is what you want to take out of this workshop. And so be prepared to take something out of this. The approach that we will use for this particular workshop is going to be looking at the thinking behind the creation of a clinical practice guideline. And I would look at it from two perspectives, aligning the reading of a clinical practice guideline, or what you look for when you read a clinical practice guideline, with how do you create a clinical practice guideline. And I use these two approaches because if you can know what to look for while you're reading a clinical practice guideline, you can bring the same elements, the same principles into what you can use when you create a clinical practice guideline. We'll structure the talk to three phases. The initial phase would be where we look at the purpose of a clinical practice guideline. The second would be where we look at the development of a clinical practice guideline. And the third phase where we would look at the implementation and evaluation. We'll have a question and answer session possibly after the second phase, after the development, and you could ask your questions and we'll look to see how we can answer those. Keep an open mind. Frank Zappa is a rock and roll musician in the US who then moved on into jazz and even classical music. As he said, the mind is like a parachute. It has to open to work. So keep an open mind on what you're going to hear, what you're going to take out from this. We'll start by the definition of what a clinical practice guideline is. Clinical practice guidelines are statements. They are statements that include recommendations. So there's no ambiguity there. There's no vagueness there. There are clear, focused, precise statements that include a recommendation for an action. And the purpose is to optimize patient care. And how do we reach these statements? How do we get these recommendations? We use, or we are informed by a systematic review of evidence. So you've got several terms that are coming here. You've got that it's a statement, it has a recommendation, it aims to optimize patient care, and it's informed by a systematic review of evidence and an assessment of the benefits and harms of alternative care options. So it's not enough to just have evidence on the particular intervention or the particular process that you are putting forth as a guideline. You also have to assess the benefits and harms of alternate care pathways, alternate care options, and present that as well. Now, this definition was created by the Institute of Medicine, which is a leading organization in the US that works on policy and decision making, and has got several guidelines, including guidelines on the body mass indices, gestational weight gain, and several guidelines. So keep these parts of a clinical practice guideline in mind when you try to slot something out, look at something as a clinical practice. Then there has to be statements, there has to be recommendations, it has to optimize patient care, it has to be informed by a systematic review of evidence, and it should provide benefits and harms of alternate care options so that you can also make your own decisions on the application or whether this particular evidence is all right or not. When do we look for a clinical practice guideline or a CPG? When we have a relevant clinical problem. Now, throughout this presentation, you might have some questions come in, and I would encourage that you look at these questions and try to frame your own answers for it. Now, when we say relevant clinical problem, we have to define what is relevant. How do we determine relevance? Now, if you're a vitreoretinal surgeon, you might look at anything or everything in the retina as a relevant clinical problem. If you're a glaucoma specialist, you might look at anything and everything in glaucoma as a relevant clinical problem. How do we determine what is relevant? Do we look at it from the perspective of magnitude, incidence and prevalence of a condition? Do we look at it from the perspective of severity, or whether the condition is severe enough? Do we look at it from the perspective of consequences, short-term and long-term consequences? How do we determine what is a relevant clinical problem? So when we are looking at a clinical practice guideline, and when we see a problem statement there, we also want to look for information on what was considered as relevance with respect to that particular clinical problem and with respect to that particular guideline. We do look at creating a CPG if there's a lack of evidence-based guidelines. If there is good quality evidence-based guidelines, you really don't want to recreate the whole process or redo the whole process. So you're looking to create a CPG when there's a lack of evidence-based guidelines. And here the questions that you have to consider, you must consider, include what do you mean when you say there's a lack of evidence? Which brings us to the question as to what is evidence? What do we consider as evidence? From a clinical perspective, from a public health perspective, what do we consider as evidence? So what do we mean when we say there's a lack of evidence? Is it really a lack of evidence, or is it that there is a lack of quality with the evidence that is available? Now, both can happen. There can be a lack of evidence. There can be quite a bit of evidence, but of poor quality. So you want to look at these factors as well when you decide that, okay, we don't have high quality evidence. We don't have evidence. And then you say, well, if we don't have these in terms of guidelines, we don't have this, then I might want to consider creating a CPG that incorporates high quality evidence into it. So again, we don't want to recreate or redo a CPG if one with a very high quality that can be applied to our population is already available. The other place where you look to develop a CPG is when you have gray areas in the clinical management practice. You're at the crossroads and you can move in one direction, you can move in the other direction. And at that particular place, it's good to have a guideline to inform you on which way to go. Which way should you take? Which route should you take? And how to go about that? If the pathway is clear, straight, it goes to one path from where you start, you really don't need a guideline there. You need to emphasize on increasing awareness of where you want to go. But you don't need a guideline for that. A guideline, by its definition, includes the term guide. So it must guide you in a particular line, in a particular direction. And you want to be guided in a particular direction when you have confusion about which direction you can go. And when there are multiple directions that you take. So that's where a guideline becomes important or relevant. Very important, we must have an evidence base from which we can create the guideline. I take you back to the definition where we said that the statement and recommendations must be informed by a systematic review of evidence. So we must have high quality or good quality evidence from previous studies so that we can synthesize that and then create a guideline. Now, if we don't have good quality evidence, if we don't have an evidence base from which to create the guideline, our first step should be to generate good quality evidence, to do a study or multiple studies to generate good quality evidence. The characteristics of a CPG, it's not enough to just create a CPG. We must see that it is feasible. And by feasibility, we mean that it can be applied by the relevant people on the relevant population, by the relevant doctors, by the relevant physicians, by the relevant subspecialists on the relevant population that needs that care, and in order to achieve expected outcomes or goals. And this is a key part of the guidelines. Sometimes that is missed, that we are developing the guideline to achieve an expected outcome or goal. That has to be stated clearly, that this is the outcome or goal that we want to achieve when we are developing this particular clinical practice guideline. It can be an improvement in patient outcomes. It might be an improvement in societal outcomes. It can be an improvement in process. But what is that expected outcome or goal of the CPG? Now, once we say that we are looking forward to achieving an expected outcome or goal, then we come to the thing that what outcome and how do we measure that outcome? Can that particular outcome be measured? So we look to see that the CPG must be something that is measurable, that has outcomes that can be measured, hopefully in this lifetime that we are. So outcomes that can be measured. And the CPG, when we are looking at it as an instrument to improve quality, to optimize patient care, we then want to also see that the CPG can lead to the development of clinical performance measures and quality of care indicators. The quality of care indicators and clinical performance measures also join in or align with the outcomes that are to be measured. Now, essentially, we are looking at the guidelines as a convenient way to package evidence and present recommendations to healthcare decision makers. So you're taking all the evidence, you're packaging it, and you want to present this as recommendations. You're taking complex evidence and you're going to break it down and you're going to make it into simple, doable statements that are unambiguous. Statements of action that can be translated into action, either by the individual physician on the ground, can be by healthcare policy decision makers, can be by societies, by professional bodies, but translated to action by some. So let's look at the development of a CPG. And when we look at the development of a CPG, we say that, well, guidelines must meet basic quality criteria. And that's an important learning that came from the development of many clinical practice guidelines, that there are varying processes that are used for the development of clinical practice guidelines, and each society uses its own processes. So when varying processes are used to develop something, it is natural to expect that there will be variation in the outcomes as well. So there are varying levels of clinical practice guidelines, if we can term it as such, varying levels of quality of clinical practice guidelines as well, that depend upon the process that has been used, the quality of the process that has been used to develop a CPG. And that learning led us to understand that standards for guideline development can help ensure that recommendations are evidence-based and can help users identify high quality guidelines. So you want standards that can help users, end users, whether it's a decision maker at a governmental level, whether it's a decision maker at an institutional level, whether it's an individual physician, that they can look at this particular guideline and say that this seems to be a high quality guideline. I can consider, based on my judgment, to use it or to not use it. And so we get standards that are aspirational, very high quality, extremely rigorous, a lot of steps. The Institute of Medicine has got guidelines, NICE has got guidelines, WHO has got guidelines. They all have standards that they have kept for their particular guidelines. You've got the McMaster. McMaster is a university in Canada, and that's got a very good global epidemiology, global health program. You got the McMaster criteria for guidelines as well. Now, leaving aside the WHO, if you look at IOM, if you Institute of Medicine, if you look at the McMaster one, even if you look at something like NICE or the NHS, you find that the standards are of a high quality, but the standards may not be possible to apply across a lot of settings, across a lot of countries. So those are aspirational standards. But when you're in an under-resourced country, when you're in a different setting, it may not be possible for you to apply those standards to the development of a CPG. So you then start looking at doable standards that can be done across more settings, across many countries. And the reason why you want to look at doable aspirational standards are good. They are the best standards that are there. You can aspire for the best quality, and that's what you want to aim for. But when you do that and you're unable to test it out or run it out in many settings across many countries, then we are not sure about the generalizability of the application of those guidelines across a large setting. Now, doable standards establish the minimum quality standards that must be there. And they say that these are things that can be done across most countries. And what the advantage that it brings in, you might argue that it possibly leads to a dip in quality, but the advantage that it brings in is that the process can be tested across many settings, across many countries, and hence can lead to a greater refinement of the clinical practice guideline to something that is pragmatic, practical, and can be applied for optimizing patient care. So we need to look at that. And we need to consider that, well, if many organizations are developing guidelines, it's natural that each one would have set their own standards. So there would be many standards that exist. So we want to see that, well, we want all of this to come into a quality package that can be looked at and evaluated and applied. And that's where the thought that we need basic quality criteria, and these have to be doable standards as opposed to aspirational standards that can be applied across many settings, came into place. Now, let me introduce you to the Guidelines International Network. Throughout this talk, I will focus mainly on the Guidelines International Network, and there's a reason for that. So the Guidelines International Network was founded in 2002. It's a network of guideline developers. It's a professional job, I think, guideline developers. That includes 93 organizations and 89 individual members representing 46 countries. This was in 2012. There are more members now. There are more representation. Now, the GIN recognized the importance of guideline development processes because they recognized that a lot of the guidelines were not getting translated into practice. So the GIN recognized the importance of guideline development processes that are both rigorous and feasible, even for modestly funded groups, to implement, and minimum standards for high quality guidelines. So the advantage of the GIN, was that it could be applied for modestly funded groups to implement, and it set out minimum standards for high quality guidelines. What they wanted to work on was to reduce the difference in quality, help adaptation to local circumstances, promote application of CPGs, and promote trustworthiness of the CPG. So the key factors that they wanted to look at was helping the adaptation to local circumstances, promoting the application of CPG and promote trustworthiness of the CPG. There are 11 key components, as I call it, 11 key criteria that go into the development of a CPG. Now we look at each of these key components, and when we are looking at each of these key components, it's something that you want to look at, that you must look at when you're reading a CPG from the perspective of taking that information and applying it. Don't get into looking directly at just the evidence that is presented or the recommendations that are presented in the CPG. You want to look at it as a complete package. And the first component that they set out was the composition of the guideline development. They said that the CPG must include diverse and relevant stakeholders, such as health professionals, methodologists. By methodologists, you mean people who are versed with research methodology, and that can include the biostatisticians, that will include the epidemiologists, that will include the clinical trialists as well. It will also include experts on a topic and healthcare consumers and health economists. Now the CPG group is responsible for reviewing the evidence, translating it into practice recommendations, writing the guideline, and assuring that the recommendations are not biased and focus on the best available scientific evidence. So CPG group has got a role to play. And its role is very important. Its role is to review the evidence, translate that into practice recommendations. So take the evidence, break it down into recommendations that can be practiced, write the guideline, and ensure that the recommendations are not biased and based on the best available evidence at that particular point of time. The group must have an effective and neutral chair as the group leader to ensure balanced contributions from all members. The primary role of the chair is only to facilitate discussion and create a consensus. Now, the chair can be someone that has general knowledge of the subject area. It need not be the topmost expert in that particular subject area. It's actually preferred not to have the topmost expert as the chair, because by the very nature of expertise, you might tend to bring in your preconceived or predetermined notions and suggestions into the discussions. So it's preferred that the chair is not someone who is a topmost expert, but understands the subject area on which the CPG is being developed. And that's to minimize the possibility of a bias that the topmost experts in that particular area can bring to the CPG. The guideline group can be varied in size. Usually you expect about 10 to 20 participants to be part of the guideline development group so that you have diversity, you have enough expertise in the group. Now you can include healthcare consumers. There's a movement to include patients and families also in the group that is developing the clinical practice guideline to understand the perspectives of them, of the patients and families, because they are the end consumers of the CPG. You apply the CPG, but the end consumers are really the patients. So there's a movement to include them. But then the problem that then comes in is that we need to bring in evidence literacy, or we need to bring in an understanding of the way that evidence is being looked at and translated into a recommendation so that the patient groups or healthcare consumer groups can understand that process. And that might require a training period and a set of training modules in addition to the development of the CPG. So although it's recommended and quite a few people want to do it, not many actually engage in doing that. So as an example, I sent this link with the material that was circulated, and you could possibly see it there. So an example description from a CPG, the guideline development group comprised physicians, ophthalmologists, community physicians, policymakers, and public health professionals from the government of India's health system and non-government service providers. So you can see that there is a diverse group from diverse settings. This is a guideline that's developed for diabetic retinopathy. from India and from schools of public health in India and the UK. And they are very specifically mentioning that it did not include the perspectives of primary level healthcare professionals or patients. So the healthcare consumers as well as primary level of care providers have not been included, but there is a diversity there. There is an expertise there in the group. There are 22 members as the writing members, and then they had a technical group that evaluated the writing, evaluated the recommendations that had 10 people. And the chair was a professor of international eye health in the Disability and Eye Health Group, London, who had an MD in surgical retina with a portfolio of childhood blindness work from developing countries. So the chair knew surgical retina, was not the topmost expert in diabetic retinopathy, had an exposure to retina, had an exposure to work in developing countries, childhood blindness, and can be neutral. The second key component, I'll share the slides later with all of you. The second key component is the decision-making process. And now that the group is formed, you want to see how do you make the decisions? How do you arrive at the final product? And the decision-making process is usually by consensus. And consensus is required for several steps. You need consensus to select what studies you want to include as part of the systematic review of evidence. You need consensus in the interpretation of the evidence that is presented in these papers. Now you can argue, or you might think that the evidence is objective. Now, even if the evidence is objective, the person interpreting is a human and can and will bring in a subjective element to that particular interpretation. And so you definitely need consensus as to what the interpretation possibly is. You need consensus to translate that evidence into recommendations. So when you write the recommendations, you need consensus to say that, well, this particular bit of evidence, we all now agree that this is what it means, and this is what it can lead to as a recommendation of action. And we need a consensus to determine how to handle situations when we don't have enough evidence to answer important clinical questions. What do we do then? How do we use whatever we have, and how do we then put that forth as a recommendation? So consensus is a key part of the development of a clinical practice guideline. And that's where the role of a chair becomes very important, to ensure that the team works together on the same page to arrive at this consensus. Now you can arrive at consensus through a formal process or through an informal process. The formal process usually is supposedly less biased, more evidence-based. And you have three techniques. You have the nominal group technique, you have the Delphi technique, which you must have read through many papers, and the formal ballot, which is just like a polling. Informal consensus process is unstructured, possibly more biased, and you just discuss with each other and try to formulate a set of consensus statements. Let's look at the Delphi process in a little bit detail. You'd see that coming across, it's possibly among the most commonly used consensus processes in the development of a clinical practice guideline, along with the nominal group. And so it's good to know what the Delphi process actually means. You can hear that through many conferences, many presentations, quite a few papers. You can hear that thrown about that we used a Delphi process. So what does that actually mean? Well, it means that you try to obtain expert opinion in a systematic manner. So experts who participate in a Delphi are polled individually. So using a poll, you're eliciting responses from each expert individually and anonymously, usually with a self-administered questionnaire. I had sent out a survey to the participants, and that can be considered as something like the beginning of a Delphi process. It's not a Delphi process, but you can look at it that way. You have a questionnaire where you can send in your answers individually and anonymously. You administer that questionnaire on yourself. It's self-administered. I'm not sitting there and asking the questions to you. Now you get those responses, and you look at those responses. You elicit it, you tabulate it, and then you report that back to the group. And this is repeated over 3 to 4 rounds, where the items that are meant for inclusion are then agreed upon. And the ones that can be excluded are then discarded. Now, a Delphi is considered complete when there is a convergence of opinion, when most people or everyone agrees on a particular statement or a particular response, or when, despite many rounds, the whole thing is not changing, it's still remaining at the same level. Then you say that, well, the Delphi process is complete. We are not going to gain anything more by doing more rounds. The advantages of a Delphi process is that you can express views impersonally, anonymously. There is no geographical limit on whom you can include. It's like a webinar, it's online. You can just include any expert from any part of the world. And so you can get different thought processes coming into the whole thing. It's an easy, flexible process and can adjust number of rounds. You can either increase the number of rounds because you're not reaching a consensus, or if you have reached a consensus, you can stop right there. So there is flexibility in the number of rounds. The limitations of the Delphi process is that you need a large number of participants for the whole process to be valid. The validity increases with the number of participants. Now, as you increase the number of participants, it's more than likely that the amount of confusion that comes into a process also increases. The amount of work that has to be done to reach a consensus also increases. The validity increases with the number of rounds because you have passed through a lot more rounds and you have done a lot of refining. However, in practice, most Delphi processes stop after 2 rounds. You have the first round, you have a second round, and then it stops. It doesn't usually, sometimes it goes to 3 rounds, but it does not usually go beyond that. And the reason for that is that experts are busy, and you keep putting the same thing back to them. Experts get bored, and experts don't want to respond after a particular point of time. So usually we get 2 rounds and then it stops. A major criticism of the Delphi process that came from the clinical epidemiology group, Sackett and others, is that we are using a questionnaire that is crude. The development of a questionnaire is a science by itself, and we are not using that science to develop the questionnaire in this particular aspect. Look at the questionnaire that I sent out as a survey. That's a crude questionnaire. It's not something that has been psychometrically evaluated. It's not something that has been looked at to see if the responses that are received are reliable and valid. It's not something that has been looked at if there are subdomains and domains and the psychometric properties of those domains. So the questionnaire development is crude, and so it can raise doubts about the validity of responses that are being collected. You also have the wonderful aspect of trying to define who an expert is and who is considered as an expert. And to be politically incorrect, that can include political machinations, that can include academic credentials, that can include experience clinically as well. And that can include exclusion of people who are otherwise experts based on several other factors. So that factor is also a factor while you are looking at who is an expert. Now, coupling that with the possible lack of reliability of the answers, the Delphi process was considered to be having quite a bit of limitations. But in the absence of a better procedure, a more easily applied procedure, that's the one that most people stick to while they are trying to develop a CPG. We just need to be aware that this limitation exists. The other technique is a nominal group technique, which is a structured meeting. People meet face-to-face, people break out into rooms. It's a group of experts that have information on working with this topic for target groups. And you then move out into breakout rooms, smaller groups, and you collect information from each participant. You assemble, in the first phase, you assemble all participants, you ask them to list individually and without discussion their own ideas on a specific topic or question. And then they get up and You do a round robin, circulate through everyone, and each person lists the topmost idea that they feel is important. And everyone talks on that, discusses on that, and votes for that through an anonymous process. And then the top voted ideas are retained and the least voted ideas are pushed out, and then the process continues. You create a chart with all of this. Now we have possibly been exposed to this, and we have possibly seen this when we have had these whiteboards, and then someone is the person who has to write, and people sit and discuss the ideas, and it's marked and said, well, approve, disapprove, keep, reject, and all those things. So that's a process, nominal group. In the second phase, you take the ideas that have come in the first phase, and then you're using a highly structured discussion of ideas on this list. Participants evaluate each idea separately and, when necessary, clarify the ideas. After the discussion, each participant privately and in writing ranks or rates the idea's worth, and then the group's view is assessed. The success of the nominal group depends on the skills of a highly trained leader who can elicit responses, can direct the discussion around those responses, and on the willingness of a group. This is a key factor. It's the willingness of a group of members who are well-versed in their subject to sit together, look at each other in a friendly manner, talk to each other, and then arrive at a consensus, even though they may all disagree in the first instance. So that's where the success of a nominal group lies. Now with a Delphi process, the advantage was that you have a group of experts, but they need not necessarily know who is telling what. They need not necessarily smile at the other expert in the room. Yeah. The third approach was the Glaser approach. The Glaser approach has been used infrequently, and it's a tiered approach. You have one person picking out a group of experts, then picking out other people that they want to include in this whole group. And so it's a tiered approach. And each tier interacts with the tier below that. The core group drafts a preliminary version. It's then subjected to internal review, and then it's sent for external review down the tiers, and then it comes back with feedback, and then it's worked on again. Now, the Glaser approach can have a leader who is not an expert in the field, but who has credibility with physicians and is good at networking and getting different people to participate in the whole process. The question that comes is, we have seen three different approaches that are used, and the nominal group and the Delphi group are commonly used. And we can see how that they are structuring that. And as you're thinking through that, this whole process is about thinking through the process of developing a CP. As you think through that, you're also required to think through the strengths that each process can bring in and the limitations that each process brings into the whole process of developing consensus. Now, why do we have a consensus approach? Because we want something that's pragmatic and doable. Ideally, you would expect that the solutions to problem in healthcare are based on definitive information and have a linear path. Problem, solution. There's a linear path. Unfortunately, that's not the case. We have many bypaths. We have many directions to take. We don't have a linear path from a problem to a solution, even if we have evidence. And so it's necessary to look at the evidence, look at the bypasses that are there, and then see which path is the most reasonable, which path is the path of least resistance to reach a solution. And that's why we need consensus. We use these techniques, the Delphi technique and the nominal group techniques, because we hope that when experts are provided the best possible evidence and the environment to then sit and evaluate that, they will come up with the best possible solutions. And so that's why the group, the composition of the group is important. That's why the process to reach a consensus is important. That's why the consensus is important. Now, the consensus, as I mentioned, is not limited only to the final statement or the final draft. It starts from the beginning, from what studies you include. What evidence do you consider? How do you interpret the evidence? How do you translate that evidence? How do you apply that evidence? and then the recommendation, and then the writing. So there is a consensus that has to be built in throughout the entire drafting of the guidelines. Major limitations. One, if you don't have enough high quality evidence, you have a major limitation. A very, very, very important limitation is the group must have the ability to assess the quality of evidence that is presented. The group must be able to look at that particular study and say that this is a high quality study. This is not high quality evidence. That ability must be there. And to do that, the group must have the ability to interpret evidence, assess the evidence, interpret the evidence appropriately, and then finally decide what is the endpoint of consensus. When has consensus been reached? Now, when you're reading a clinical practice guideline, you have to check very carefully how consensus was arrived at for the development of this clinical practice guideline. That has to be explicitly stated and must be determined before the start of the development of the CPG. If you are aiming to create a CPG, you have to be very clear before you start the whole process about how you are going to define consensus, for each of the subcomponents. And to make things nicer, you have to have consensus on how you're going to reach consensus as well. So as an example from the same CPG, the link that we have sent through the material, different components of the guidelines were allocated to our technical experts to write the first draft. The drafts were then reviewed and decisions were made for areas of improvement. The draft, including the recommendations, was completed by a smaller writing who adopted, modified, added to the recommendations for each PICO question. This entailed updating the literature search. The draft guidelines were sent to members of the technical committee and external experts. Anonymous voting was used to reach consensus on each of the recommendations after amendment following discussion. So they've used anonymous voting to arrive at consensus. They have a process mentioned how they are writing it, how it has been sent for external review. And there's a technical group for that, plus external experts, and then how they have used anonymous voting to reach consensus for each of the recommendations after it has been discussed and amended. The third key component of the development of a CPG that you need to look for is the conflicts of interest, personal, professional conflicts of interest, financial, non-financial conflicts of interest disclosures. You're not wanting to look only at a conflict of interest. You're wanting to see how that conflict of interest is being resolved as well. So the resolution of a conflict of interest is very, very important. And that has to be mentioned very explicitly. The fourth component is where we discuss the scope of the guideline. And there we have to mention very clearly the objectives and the key questions. And that can include diagnostic criteria, that can include benefit and harms of various treatment options. It can include key outcomes, target patient population, intended users of the guideline. From the same guideline, the scope of guidelines is wide and includes recommendations for the following: the prevention of diabetic retinopathy in people with diabetes, approaches to the early detection of DR by screening and opportunistic examination, clinical investigations for the diagnosis of retinopathy, clinical management of the different types and stages. It also includes recommendations for the management of cataract in people with diabetes. It does not include primary prevention of diabetes, control of risk factors. So it states very explicitly the scope of the guidelines. So you can look at that and then you can decide that this is something that you want to continue looking at, or is something that applies for your particular patient population. So the scope of the clinical practice guideline must be explicitly stated in clear, precise terms. So from the link that we had sent, the purpose of the guidelines, I keep saying from the link that we had sent in the hope that some of you might have actually opened it. But if you have not opened it, I will be sending the slides later and you can open it and look at it later as well. So As an example, the purpose of the guidelines is to provide recommendations to relevant audiences, anticipating the likely increase in the incidence of visual impairment and blindness from diabetic retinopathy as the diabetes epidemic in India continues and matures. The guidelines are intended for a wide audience, including policymakers and service planners, and a wide range of healthcare professionals who provide services for people with diabetes and eye care at all levels in the health system. So the purpose includes the last sentence, healthcare professionals who provide services for people with diabetes and eye care at all levels in the health system, but the group actually did not include people who are working with this particular problem at the primary care level. So you start looking at that as well, that in that process, is there a possibility that the recommendations for a primary care or at a primary care level may not have been adequately addressed. Now, the fifth component is a very important component, and that's the description of the guideline development methods. So you can see we have now reached the fifth component. We have had 4 components that we want to look at very carefully before we actually start reading the guidelines. And the reason we are looking at this carefully is that we want to ensure that there is minimal bias, or that bias has been minimized, and that this particular guideline can be trusted or is trustworthy. There is enough expertise there. There is a minimization of bias that we can look at these guidelines and its results with trust. The guidelines development methods is a key component to building that trust and for you to make that evaluation. So what do you want to look for when you look at the methods? You want to see the process that has been used to choose the group members and a chair. Now, if you look at most guidelines, you can see the names of members there. You can see the name of the chair there. But the process that has been used to develop the group members and the chair may or may not be there. But you want to see that. You want to see that a transparent process has been used and that it has resulted in the accumulation or the addition of excellent people to the group. You want to see the methods that have been used to review the evidence. It's a key part of it. You want to see the methods that have been used to review the evidence. You want to see the process that the group has used to deliberate about the evidence and formulate recommendation, whether it's a Delphi process that they used to arrive at a consensus, a nominal group. Beyond that, the process that they used to review, synthesize, collate that evidence, and any pertinent review or approval process. So what is the process that is used to approve the final output? What's the process that's been used to approve amendments? What's the process that has been used to review? Now, all of this is for you to see, for the reader to see that there is minimal bias involved, or to assess the amount of bias that might be involved in the development of the guidelines. So from the same CPG that we had seen earlier, a literature search was undertaken by an information scientist, Cochrane's Eye and Vision Group, using extensive search terms, included other countries in Asia to provide regional evidence if this was not available for India, if evidence was not available for India. Systematic reviews were preferentially used to formulate recommendations whenever available. And if its systematic review was not available, you are looking at RCTs and other designs. The literature was searched for additional and more recent evidence during development as required. There is detail there that can be more detailed, but it gives you a sense of how they have gone about looking at the evidence. How did they form the group? They are describing that here. They're saying they formed a national task force in 2014, and then they formed a technical expert group in 2015, and the group met 5 times. And they used a particular process. That's the WHO's handbook for guideline development. So you're seeing that they're describing the process of forming the group there, not in greater detail, but there is a sentence there. They're describing how the technical group was formed. They're describing the number of meetings that they held, and they're describing the days upon which they set these processes, the World WHO's handbook for guideline development. So there is information. Now we come to the key component, the component that is very essential to know as you look through a clinical practice guideline, as you're looking through the creation of a clinical practice guideline, as you're looking through the reading of a clinical practice guideline as well, when you're looking at the individual studies that make those up. For the guideline to be trustworthy, it has to be based on a high quality systematic review. A high quality systematic review also requires high quality studies that form the evidence. So we'll look briefly at what a systematic review is. It uses rigorous methods to identify clinical questions. It has got inclusion, it has got exclusion criteria, and then it's got methods for rating the quality of evidence. There are two terms that are used, a systematic review and a meta-analysis, and both are slightly different from each other. A systematic review is objective, reproducible. You find answers to a certain research question by collecting all available evidence from studies that have been done relating to that particular question. You review that, you analyze the results, and then you come to an interpretation. Where that differs from a meta-analysis is that the meta-analysis includes a statistical process that works on the estimates of the individual studies. So usually it's 2 or more studies, works on the estimates from the individual studies to create a pooled estimate. A systematic review can lead to a meta-analysis, or if you don't have the statistical expertise for that, you can have a systematic review that reviews, collates, and presents a descriptive analysis of the results, what we call as a qualitative analysis of the quantitative data. You're presenting a description that this study found this odds ratio, risk ratio, confidence intervals, and you're presenting it study-wise. In a meta-analysis, you're taking all of that information and then you're combining all of that, and then you're creating a pooled estimate of all of that. So you can say that over the 10 studies that we had included, this is the pooled estimate based on the results of all these 10 studies. So that is the difference between a meta-analysis and a systematic review. The process essentially is to derive a conclusion with an increased power and accuracy than what is possible with an individual study. Now, before you do that, before you get into the meta-analysis, before you get into the systematic review, there are certain things that you want to look at. You want to look at the direction and size of the effect. When I say effect, it is the effect of the intervention, or effect of the process, or effect of the procedure. What is the direction and size of the effect? You want to look that the studies are nearly similar in terms of methodology and processes that are used. So you're looking at homogeneity of the studies, and you want to also see that the results are also nearly similar. So you're looking at homogeneity of effects among the studies as well. Homogeneity in the terms of being similar. And you want to look at the strength of evidence based on the methodological processes as well. You look at that before you start your systematic review. You look at that before you start your meta-analysis, because if the strength of evidence is poor, if the direction and size of effect shows that it is not very high, it is not large, it is questionable, you don't want to include that in the final meta-analysis. So you're now working through the process of looking at the study to also see if you can include or exclude the study from the meta-analysis. And that's where the ability to look at evidence, the ability to look at a paper, the ability to review a paper becomes important. Oftentimes we think of reading a paper as just looking at the results and then taking those results as it is. That is not the way that we should be looking at it, because there can be a lot of dicey things happening there, and you need to be able to look at those results with a critical eye and make out whether what you are seeing is true or not, can be accepted or not. So you look at several things in the analysis. We look at the effect size, we look at the heterogeneity, we look at individual odds ratios and confidence intervals, risk ratios, risk difference and confidence intervals. Pooled estimates, we looked at what we call as a fixed effect model or a random effect model. We'll look at these very briefly. When we look at continuous variables, we are looking at the mean difference, which is the absolute difference in the mean values between groups. The mean of group A minus the mean of group B. What's the difference? Standardized mean difference is the mean difference between groups that is divided by the standard deviation. Now, if all the studies are using similar units, we can present the mean difference. If some other studies are using a different unit, kilometers, meters, different units, then it's preferable to use the SMD, standardized mean difference. If the value is 0, a value of 0 for MD or SMD, it means that the effects of the new treatment method and the existing treatment are same. There's no difference. If the value is less than 0, it means that the new treatment is less effective than the existing treatment. A value greater than 0 means that the new treatment is more effective than the existing method. So that's how you interpret the MD and the SMD, and you have to make a decision on what you want to use. Can you use the MD? Should I use the standardized mean difference? And this is how we interpret that. When you're using categorical variables, dichotomous variables, we look at the odds ratio, and risk difference. Again, that's dependent on the design of the study. Now, if you're looking at an RCT, if you're looking at a quasi-experimental study, a non-randomized clinical trial, or cohort studies, we look at the risk ratio or the risk difference. If you are looking at a case control study or a cross-sectional study, we can look at the odds ratio. So the choice of a risk ratio, RR or an RD or an OR, depends upon the design of the study as well. And the design of the study then becomes important. If the outcome variable is a dichotomous variable, it can be presented as the number needed to treat as well, which is a minimum number of participants who need to be treated to get one additional good outcome than expected. So you're comparing the interventional control group. We won't go into the details of this right now. So let me show you a forest plot. And if you look through the table there, you can see towards the end, closer to the figure. To the figure, look at the figure, and just to the left of the figure, you can see the risk ratios being presented. The risk ratios have got Mandel-Hansel risk ratios. It's got a point estimate 0.42. It's got 95% confidence intervals within the parentheses. And the figure shows that based on a line and two boxes on either side of the line. You've got a box that says it favors the experimental treatment, a box that says it favors the control. And if anything is on the central line or crosses the central line, that means there is no difference between the experimental group and the control group. If anything is only on one side, as you can see, two boxes, two lines here, 2 point estimates and two boxes, the ones in blue, square ones. They are towards the experimental side. So they're not crossing the central line. They're not moved into the control line. You're not looking only for the point estimate, the central dot to be only on the central line. Even if the lines that move from the central estimate on either side, that's the confidence intervals, cross the central line or are spread across the two groups, they're no longer significantly different. In the bottom, you can see, in the bottom of the top figure, you can see a black mark. That is a pooled estimate. And if you look at the bold here, you can see that the pooled estimate is 0.81 with a confidence interval of 0.67 to 0.9. So it's not touched that central one line. It is favoring an experimental treatment. So that's the risk ratio. And you can depict it as a figure. You must depict it as a figure as well as with the point estimates and the confidence intervals written down. as numerics. I'll send these slides. I'll send it to Sudha and she will circulate it, or I'll send it to all of you so you can take your time and look at this again. We'll also look at heterogeneity next. Heterogeneity or homogeneity test is a method whether the degree of heterogeneity is greater than would be expected to occur naturally, whether the difference between the studies is greater than you would expect to occur naturally, or is it greater than the anticipated sampling error. It makes it possible to test whether the effect size that is calculated from several studies is the same, or is there a difference. And you can use the forest plot that we have just seen. We can use a Cochrane's Q test, which is based on a chi-square, and the Higgins I-squared statistics. How do you interpret that? I'll show you the figure. How do you interpret that? If there's a greater overlap of CI, it means that there is greater homogeneity. They're nearly similar. Once the CIs overlap, there is a lack of statistically significant difference, and hence there is greater homogeneity. The Q statistic, if it's less than 0.1, it means that there is statistical heterogeneity. They're no longer similar. I-square returns a value between 0 and 100%, and if the value is less than 25%, strong homogeneity. If the value is more than 75%, strong heterogeneity. So if you look down here, you can see below the bold, if you come down, we look at the top figure, and below the total, the one that has been bold, you can see that blue highlight mark. The I-squared statistic says it is 88%. If it's 88%, it means that it is strongly heterogeneous. By the side of that, you can see the heterogeneity chi-squared, and you can see the p-value less than 0.001. And we had said that the Q statistics, if it's less than 0.1, it indicates strong heterogeneity. So if you look at this, we can see that there is strong heterogeneity there. And now if you look at the risk ratios there, you can see that you have one particular study which has a risk ratio of 14. You have some which have a risk ratio of 1, you have one which has a risk ratio of 2, and then you have a spread 0.14. So you have a spread from risk ratio of 0.14 to 14. So it is heterogeneous. There is a wide difference between the estimates from the different studies, which might be related to the methodology, which can be a true difference as well. But it is heterogeneous, and that is seen by the I-squared statistic as well as by the Q statistic. The next part that we have to look at is the model. A fixed effect model assumes that the effect of treatment is the same. The effect of treatment is the same, and whatever variation that you are seeing between results in different studies is due to a random error. It has occurred by random, by chance. Fixed effect model can be used when the studies are considered to have the same design. You've taken all RCTs. You've not included a cohort study. You've not included a case control study. They're all RCTs only, and they have followed the same methodological processes. And when there is only a small difference between the results across these studies, these different studies, then you can say that, well, it looks like they have all used similar processes. They were all based on the same design, and the variability is small. So the variance might possibly just be random. It need not be a true variation. It need not be a true. It can be, but it need not be a true variation. So you can use a fixed effect model there. The random effect model assumes heterogeneity between the studies. It says that the studies are different, methodologically different, process-wise different, results different, different effects of the intervention. So even if the heterogeneity test does not show a big heterogeneity, strong heterogeneity, you can still use a random effect model, assuming that there is heterogeneity, but we are not being able to pick it up. And it says that the difference between studies is not just by random. It's also because there is variability between the study processes, study participants, study measures as well. So that's when you use a random effect model. So let's come back to this forest plot, and you can see on the top, A is a fixed effect model. and B used a random effect model. Now let's look at whether this was appropriate to use and whether that makes a difference or not. So if you look at the fixed effect model, that's group A, you can see that the I square was 88%, strongly heterogeneous. The Q statistic or the chi-square statistics, P was much less than 0.1, again heterogeneous, but they used a fixed effect model. What I talked to you a little while ago was that the fixed effect model should not be used if there is heterogeneity. It assumes homogeneity. If you are finding homogeneity, use a fixed effect model. So they've used a fixed effect here, model here, and then they have calculated the risk ratio, and you can see the pooled estimate coming to 0.81. And if you look at that black dot, you can see that it is now favoring the experimental treatment because it's on one side. It's in the box that favors the experimental treatment, and it has not crossed that central line, the line from 1, and it has not moved into the control. So it's not crossing that line. So the fixed effect model says that the intervention is favoring the experimental intervention over the existing intervention or the control. But now let's look at, given that there is a strong heterogeneity, let's look at what happened when they used a random effects estimate. And now you find that the pooled estimate is 0.83. There the pooled estimate was 0.81. Here it's 0.83. And you might say that, well, it's only 0.2 different. So is that really 0.2 different? Is that really 0.2? Is that really significant or not? Look at what happened with the confidence intervals. The confidence intervals for 0.81 was 0.67 to 0.99. Here it became 0.39 to 1.76. And more important, in the bottom figure, look at what happened to that black box. The black box has crossed the central one, and it's moved into the control as well. So it has crossed the central one to the control box from the experiment. So now it's no longer significant. Can you make that out from the confidence intervals? If the confidence interval is on either side of 1 or it's crossing 1, 0.39 to 1.76, then there is no significant difference, statistically significant difference between the experimental group and the control group. So you can see the difference that comes in based on the model that's being used. If we had relied on the fixed effect model, we would say the experimental intervention is more effective compared to the control. When we do the more appropriate random effect model, because there's strong heterogeneity involved, then you find that, well, they're not actually different from each other. So when you're looking at the results of a systematic review, when you're looking at the results of a forest plot, you have to also look at what the appropriateness of the model that is being used. Again, the slides will be sent. Take time, look through this, and you can always get back with your doubts, and I'll be more than happy to clear that for you. The next component that we want to look at is publication bias. Now we know about publication bias. We have heard about publication bias. We know that studies that show a positive result are more likely to be included in a journal as opposed to studies that show a neutral or negative result. Can we find out? Can we look for publication bias? Well, there are ways to look for it. So we can look at a funnel plot. Funnel plot is where the studies are plotted on a scatter plot with effect size on the x-axis and the precision or total sample size on the y-axis. And then you look at the funnel. I'll show a figure here. So you have figure A, where you have a funnel that's narrower at the top and it's broadening at the bottom. And if you look at it, the dot, it's nearly symmetrical. There are few dots, circles beyond 0. I marked 0 there with the yellow. There are few dots on one side of 0. There are dots on the other side of 0. But the funnel is nearly symmetric. Compare that with funnel with picture B, where you find that there are no dots on one side of 0. You have a dot that you can say, a black dot on top that you can say is on 0, but there's no dots on one side of 0. So the funnel is asymmetrical. And you can see that asymmetry in the in the diagrammatic representation as well. Now, an asymmetrical funnel indicates that there is publication bias. It's skewed towards one direction. A symmetrical funnel indicates that there is no publication bias. So you can put these estimates there and then you can see whether there is a publication bias or not. You can take that further and test it using some tests. I'm not going to the details of that. You can use the Begg and Masundar's rank correlation test, Egger's test. And once you detect a funnel publication bias, you can actually use a trim and fill method to correct the bias and then derive a pooled estimate. So you can correct for that as well. We'll not go into details of that, but these are things that when we say that we are looking at the evidence that goes into a clinical practice guideline, these are things that people usually must look at. These are things that people usually look at when they create a clinical practice guideline. The review of a systematic review, we have got the PRISMA 2020 guidelines. I have sent the link for that. I would recommend that all of you go and look at it. It's a guideline for the reporting of systematic reviews. It's got 27 items checklist, and it can help you with the reading of a systematic review to see if all the things that have to be met are actually met. You've got the eligibility criteria of studies that are to be included. From where are you picking the studies, which databases, the search terms that are used, selection of individual studies, data collection processes, data items. You're looking at effect measures, synthesis methods, how is the data being synthesized. So all of the things that we talk now come into the picture here. You're looking at meta-analysis models, assessment of heterogeneity, reporting bias assessment, publication bias. And all that you want to do is that you have enough certainty or confidence in the body of evidence that you have collected and analyzed and put out as a pooled estimate. The seventh component. So now you have looked at the evidence, you have to translate that into recommendations and to translate that into statements with clear direction. These must be statements in the active voice, unambiguous. There's no consider using this. There is no that can be used. There is no this can be used. It must be very precise. If this is there, this must be done. You're supporting the recommendations by evidence. You're supporting the recommendations by quantification of the benefits and harms, cost involved, resource and feasibility, how to implement, implementation considerations, and preferences, ethical and legal matters. The same way that you rate evidence, the guideline must rate evidence and recommendations. So it must have a rating system that is used to communicate the quality and reliability of both the evidence and the strength of its own recommendations. So I'll introduce you to GRADE. GRADE is the grading of recommendations, assessment, development, and evaluation system to grade evidence. We remember the hierarchical pyramid that we have seen, where the systematic review is at the top. You have the RCT below that, you have the cohort study below that, the case control study, cross-sectional study, case reports, anecdotal evidence. This is a different system that looks at the quality of evidence, the quality of recommendations, and it makes it more simple that can be understood by any clinical practitioner out there in the field. And the quality of evidence is based just on 4 categories. One is high quality. And high quality means that further research, you feel that further research will not change the confidence in the estimate of effect, will not lead to any further change. Moderate quality is where further research can change the estimate. So there can be some changes in the estimates. Low quality is in where further research is very, very likely to create a change in the estimate. And very low quality is where the estimate is very uncertain. So you have just 4 things there. And what you want to look for is high quality, where you're seeing that further research, further studies in that particular area are very unlikely to change the estimates. Now, when we say the quality of evidence of an RCT, when we look at an RCT and we say that it's a high quality, it's an RCT, so the evidence is high quality, we must also factor in that if there are methodological problems or limitations with the design and conduct of the RCT, the evidence can be downgraded or must be downgraded. So it's not enough to just say that because it's an RCT, it's the highest quality evidence. If the RCT has got design problems, if the RCT has got inconsistency in the results, if the RCT has got indirectness of evidence, impreciseness in its estimates, the quality of evidence is, the rating of evidence is brought down. If it's a observational study, a cohort study or a case control study, usually say that it starts from a low quality effect. But if it finds a big difference, a large effect, you can rate up the quality of evidence. And you can rate it up because the effect is so large that further studies are not going to change that too much. If there's a dose-response relationship, where if you increase the dose of an intervention, the response proportionately increases, then you can again rate up the quality of evidence. So when you're looking at the design, it's not a given that just because it is a randomized clinical trial, it is the highest quality of evidence. It's not a given that just because it is a cohort study design, it is a poor quality of evidence. You can rate it down, you must rate it down or rate it up appropriately. GRADE offers two types of recommendations. One is a strong recommendation, the other is a weak recommendation. So it's simplifying the levels of evidence into just 4 categories and 2 grades of recommendations. If the effects of an intervention, desirable effects of an intervention, clearly outweigh the undesirable effects, or on the other side do not, then it's a strong recommendation. You can make a strong recommendation. This must be done because it clearly outweighs benefits. This must not be done because the harms are clearly outweighing the benefits. If the trade-off is less certain, or there is both are close together, then you can offer a weak recommendation there. And you say that, well, we are recommending this, but this is a weak recommendation because the two are nearly similar to each other. So those are the 2 grades of recommendations that are to be applied in a clinical practice guideline. If you look at most clinical practice guidelines, I wouldn't say most, but a lot of clinical practice guidelines, they provide a rating of the quality of evidence, but many do not provide a rating of the recommendations. And that's something that the GIN brought in using GRADE. There are other frameworks as well to do this, but GRADE is the one that's most commonly used. So using GRADE to rate the quality of recommendations as well. Now, anything that you have then put out, you have to then send out to external stakeholders. It can be a technical group that's set up earlier, as well as external peer review. And then you're collecting information and feedback on this. And that process has to be mentioned clearly in the guideline. So as you're developing the guideline, as you're reading the guideline, you're going to see how did they do the peer review of this draft. And that's something that must be looked at very carefully. Very important, every guideline must have a date of expiry. And usually the date of expiry is within 3 months. Sorry, 3 years from its development. That must be clearly set out. This is this particular guideline, version number this. This is the date on which it is being set out. This is the date of expiry. And there must be a clear statement that if this particular guideline has not been updated after that date, this particular guideline is considered invalid for use after that date. So there is no using this guideline after the date of expiry. It has got a date of expiry. And the guideline must set out the process that's then used to update the recommendations as well. The 11th is the financial support and sponsoring organization. You want to make sure that people are not getting money to write what they want you to write. You want to make sure that there is independence from the sponsor and that the guidelines are unbiased. Now, the question that really comes in is, do I need to read all of this Do I need to look at all of this when I read a clinical practice guide? And the whole process is meant to ensure that there is a minimal amount. We can't always avoid bias. We can't remove every bit of bias that is there, but the whole process is meant to minimize bias so that the final output, the final guidelines are trustworthy and can be applied. So when you read a guideline and you say that should I apply this on my patient? You want to make sure that there is a lack of bias or there is only very minimal bias, and to account for that as you make your interpretation. And that's where all these factors come in. So usually when we look at a guideline, we tend to, I can speak for myself, I would tend to look at the title, at least before, I would tend to look at the title, and then I would straight away go to what the main results are. I would go to what's the quality of evidence. So they said RCT, wonderful, RCT is the highest quality of evidence. I don't need to look at anything else. I would look to see if there's a recommendation, and then I would say, well, they recommended that, so I am doing this. And then when I do that on a patient, I find that something else is happening there. And then I'm a bit confused. Why is that something happening? Isn't it? So this whole process of looking at a guideline in a systematic manner is to ensure that we minimize bias. Equally important, the whole process of looking at a guideline in a systematic manner actually sets you on the path to creating a clinical practice guideline of a very high quality, because you just need to make sure that you're taking all these processes and applying it. So both are interlinked. The reading of a clinical practice guideline is interlinked with the creation of a clinical practice guideline. You can read a good clinical practice guideline. You can create a good clinical practice guide. And that's something that happens with the reading of a paper as well. If you can read a journal paper well, you can design a scientific study well and do that scientific study. So both are interlinked. So here I am. This is my latest picture. And we can take questions at this point of time if you want, or we can move on and take questions at the end, depending on the comfort of the group.
Sir, we can take some questions because there are some questions in the chat group. So
No problem.
Let me
Yeah.
put those questions to you, sir. Okay,
Yes.
As not surprisingly, one of the first and frequently asked questions are about the legal implications of clinical guidelines. Does this support one in a medical issue? If you have, say, followed particular clinical guidelines, and then subsequently you end up in a medical legal case, you can, does this support you in a medical legal issue? That's the question.
A good question, and one that I anticipated. Now, the clinical practice guideline is not supposed to be a legal document. If you look at it, most clinical practice guidelines that come now clearly state that these are not meant as a legally acceptable document, or a document that has to be used for or can be used for legal purposes. So disclaimer is, and the reason for that is the clinical practice guideline is a framework. It's a framework that you have to adapt based on your experience and your judgment and the individual patient sitting in front of you or lying down in front of you if it's on the surgery table or whatever. So the practice guideline is a framework, and the practice guideline is not meant to supersede the knowledge, experience, and judgment of the individual physician. That is not its purpose. The term is guideline. It gives you a guide. It shows you a line. But you have to use your judgment. You have to use your experience. You have to use your expertise to then say that I will apply this or not. So this is an important part that I feel the medical fraternity should highlight, because from a legal perspective and from a patient perspective, it often gets confused that the guideline is the Bible. And if you have not done what's in the guideline, you have done a grave sin. That is not the purpose of a guide. And that has to be brought out very clearly. So if you are using it in a legal situation, if you have got into trouble that you have not used a particular step, you have not followed a particular step of the guideline, if the particular situation of the patient warrants that, you're justified in that deviation. The difference is you will be quizzed on the guideline. You have to know and have enough backup information to say why you made the deviation and to justify the deviation with evidence.
Yes. Yes.
But the important thing is that we must put out the message that guidelines are not a legally binding Bible, and that the individual physician must only stick to that. It's not what it's meant for.
Yes, sir. I think just building upon that point, I think 2 points. One is, I think if you are deviating from a well-established guideline, it probably helps to, this is what one of my professors told me in one of the seminars, which was conducted on glaucoma about a couple of weeks back, that if you are writing something that is slightly different from the established guideline, just make a note in your case sheet that you are not doing this because of so-and-so. That might actually help you subsequently.
Yes.
And the other thing is, while it is true that, okay, you have not performed a particular process that has been described in the guideline, but should it not also help you in another way, that if you have practiced everything according to the correct guidelines and still there is a medical legal case because of an adverse outcome, you can use the fact that you have performed the guidelines in support of your own cause?
Yes, you can. You definitely can. So that when you have used the guideline, you're on a stronger ground saying that I have followed what has been prescribed and what is common knowledge and what is taught in the management of this patient. When you're deviating, you document that and you have a clear justification for that. Now, for both, the key point is probably not so much as to whether you followed the guideline or not. The key is whether or how good and strong your documentation is.
Yes, yes.
So if you have documented all processes, it's very easy for you to say, well, here's a guideline, here's my document. If you have documented the deviation properly, you can say, this is why. But if your documentation is not appropriate, that's where you usually start getting into a bit of trouble, because then it becomes a subjective element that is not very objectively laid out there.
All right, sir. The second question is, again, I think partially answered, but I think, I mean, how do you look at clinical practice guidelines from an individual practice level? I think what you said is already, probably touched upon that it should not supersede your, individual clinical judgment. I think if you have any more points to add to that, sir.
No, I think that at the end of the day, every one of you must figure out that you have worked hard. Whether you have really worked hard or not, you be the judge of that. I'm not judging that, but you have worked hard to reach a position where you have, and you have a wealth of experience. You have a wealth of experience that is guiding your treatment. There can be objective measures. There can be an instinctual, intuitive mechanism as well. You need to trust that. And you're taking evidence and you're applying it with the intuitive knowledge and experience that you're not taking evidence as a standalone pillar and putting it on your head and saying that I have put it there and now everything is all right. No, it has to build on your intuitive experience. It has to build on your clinical judgment. It has to build on the work that you have been doing. So don't discount that part of it and don't feel that that part of it is not important. So I would definitely say that it should not supersede. You're using this as a framework to help you add on to the work that you are doing. You're not using this to replace the work that you are doing or to replace your expertise.
All right, sir. So Dr. Manoj, I don't know which Manoj is this. It's just showing Manoj's iPhone. He has a lot of questions. Is this Dr. Manoj from our glaucoma Manoj or retina Manoj? I don't know. But so he has
retina Manoj.
Okay, Dr. Manoj. Yeah. Okay, right. So he has a lot of questions. I will ask them. So one of the questions is regarding data from local community. So if we, for example, do not have any data from the local community, then do those guidelines really suffice?
If we don't have data from the local community, we must be cognizant of that fact, and we must be aware of the fact that when we adapt these guidelines, when we try to put these apply these guidelines, there can be variations in the outcomes. But it may not always be possible to get data from the local community. It may not always be available. Then we are using the next best possibility there. But with the understanding that there can be variations. So you're going to keenly look for, you're going to keenly observe if there are variations that occur.
Okay. I just think to expand on that particular point, Dr. Manoj, in glaucoma, for example, the two commonly practiced guidelines, at least which are available for us, one is the American Academy of Ophthalmology's preferred practice patterns. The other is the Asia Pacific glaucoma guidelines. Asia Pacific glaucoma guidelines are actually more tuned towards our population because a lot of authors from India as well as part of the guideline program. And in fact, in the International Institute of Public Health guidelines on diabetic retinopathy, I'm a glaucoma practitioner, so Dr. Manoj might be knowing this. I think the data is very much tailored towards India, isn't it?
Yes.
So we have, at least for the major diseases, guidelines which are adapted to our local community. And the other question again, Dr. Manoj want to ask is whether this will disregard small-time practitioners because they may not have access to more advanced evaluations, multimodal evaluations. So whether the clinical practice guidelines vary with levels of care, with primary or secondary, tertiary care like that. Yeah.
Manoj, I am with you on that particular question, and that's a complaint that I have with the whole process. But I don't have a complaint from the development of the guide. I have a complaint that we are not involving ourselves with this. It's one thing for us to sit and say that the small-time practitioner or the individual, I don't know what a small-time practitioner is. Everyone is a practitioner, but the individual practitioner is not being represented in the whole process. That's a true fact. And it's also a true fact that most guidelines tend to focus now more on the higher end systems, and hence they cannot be translated to the primary or even secondary care. But the problem really is that if I can be the devil's advocate, I'm the devil anyway. So if I can be the devil's advocate, we are not involving ourselves either in terms of doing studies, in terms of creating evidence, in terms of putting out or discussing our evidence from the primary or secondary care setting. Yes. And if you're not doing that, we're not going to expect someone else to come and say that I am going to use this particular evidence. The evidence is then going to come only from a tertiary care setting or a high resource setting that is doing it. So ultimately, you tend to look only at the evidence that you can get. The danger is there, and it's a true danger that the primary and secondary care level get diluted. We are setting an artificial benchmark there. So when we were doing the glaucoma study, when we are doing the population-based studies at that time, the benchmark was that for glaucoma, you have to do a Humphreys visual field.
Yes.
Now you go out to a village with a Humphrey automated pyramid. You can't go in the first place where there's no road. How do you take that big damn thing there and then you put it there and then you will only see people running away from you? Yeah. So then if you say that, well, I am defining glaucoma and field loss and all this thing and defining glaucoma based on this, the pushback is that where is your Humphrey? Where is your visual field? And so then you fight back saying that, well, this is what is pragmatically possible in these settings. And based on this, this is our evidence. The evidence has limitations, but we need that feedback. We need that communication. We need that coming from the primary and secondary care as well for the clinical practice guidelines to be applicable across all levels. Otherwise, you have a high resource setting anticipating what is possible. I'm not saying that that is bad. I'm not saying that they missed the mark, but the possibility of missing the mark is there. Anticipating what is possible at the primary and secondary care level, or even a tertiary care center in the public sector that is not having enough resources.
Yes, yes. All right, sir. But at the same time, you mentioned about you have so much of experience in conducting rural surveys in Andhra Pradesh, and but if you look at the situation in Kerala, I don't think there is any practitioner who is practicing, who wouldn't have a Humphrey visual field. Who wouldn't be practicing glaucoma. And similarly, I'm not really very well versed with the retinopathy guidelines, but I think they are very, very clear about what needs to be done. For example, it is written that a dilated fundus evaluation is mandatory, that everybody can do. Then if you are suspecting a diabetic retinopathy and you're suspecting a diabetic macular edema, then you do an OCT. And now, so that is very, very clear, isn't it? So it's actually quite, I wouldn't think that they are not recommending an ICG for every patient. I think very pragmatic guidelines, actually.
Exactly. I'll build on that, Kiran. I'll build on that. The thing is that we are doing it and we have this data, but the data is staying with us. in our clinics, in our case record. So if I do a literature search, I don't see any of that coming, even if it's from Kerala. I don't see any of that really coming up in the algorithm. And so what I end up being is the evidence that I can collect. And that's why I'm saying that we must move to sharing this data, putting this data. We are doing it. It's only a matter of now starting to putting that out, that this is what it is. And then we end up bringing in a better refinement to the whole process. Okay. Rather than sitting at a tertiary level and saying that at a primary care level, try doing this or look at this, brings it to a better level.
Okay, Dr. Manoj, another question actually with regard to the forest plot you had shown in your slides earlier, that when the fixed rate analysis was done in the first part, and if you looked at the pooled estimate and the confidence interval had gone up to 0.99 in the fixed rate itself. So from this point itself, he is asking whether this itself indicates the weaker strength of the treatment modality from or the.
Well, there are different ways to look at a confidence interval. Now, one of the ways to look at it was to look at the margins, at the lower margin and the upper margin. Okay. So in that case, it was 0.39 and 0.9. And you say the upper margin 0.99 is very close to 1, and so it possibly is a weak effect.
Yes.
That is a conventional way of looking at it, and that has been proven to be a not so good way of looking at it. Okay. So all that we are saying now is that it is on one side of 1. So there is a significance there. Okay. We are then looking at the pooled estimate. It can be very close. It can be a very good effect because 0.39 is at the other end.
Yes.
It's far away from 1. So the possibility that it can be very, very close, mild, weak effect, it can be a strong effect is there. So the interpretation of a confidence interval has changed, I can say, to a certain extent, to a large extent, to a point where like the p-value, it is now being looked at as possibly being, I'm getting into possibly being more irrelevant at this point of time. So the interpretation is not so much that it has to be, it is a weak effect or anything. It's just saying that it is showing that a lot of times, 95 out of 100 times when we replicate the study, it is sitting at this side. It is not crossing.
All right, sir. Okay, another question, I think you had alluded to this in the talk itself about how often the CPGs needs to be amended because the treatment options, etc., need to change from time to time. You mentioned, I think, 3 years, is that?
Yes, usually 3 years. It's almost like how we update the IEC requirements or the NABH and all documents, NABL documents, 3 years to 5 years. The thing we have to remember now is that things are changing fast. So earlier you could spend a year or 2 developing a clinical practice guideline. Now you can't because things change very fast. You need about 6 months to put it all out because evidence changes, assessment methods changes, a lot of studies keep happening. So now it might need a yearly look to see if this particular evidence still holds good or not. But if it is changing in between and you want to add an amendment, then what is the process for that amendment? If it is not changing, 3 years definitely cut out and then say that the next guideline has to come.
Okay, there's another question with regard to a legal matter. Dr. Devika wants to know if the guidelines as per the CPG and your textbook, varies a little. And that if the issue arises in court, will sticking on to CPG will help us, legally, I think.
Well, the thing I find with the legal arguments is usually that we sort of play subservience to the legal arguments there. And we don't really put out our points quite strongly. The textbook is based on a collection of information that is written by a set of experts and pulling out information from a period of time. The textbook has an expiration period. The textbook articles pull information from a certain amount of period. So the textbook may or may not be relevant at that particular time for you to hold it up in court. So when an advocate or a legal person tells you that, but this textbook says this, you can always get back and say that this is the latest evidence. The textbook is a bit outdated. And so I'm sticking to so the thing is, the amount of conviction you bring to the evidence that you are presenting and the justification. So the guideline, if it is recent and the guideline is pulling from recent evidence, then the guideline has got greater weightage than a textbook. They can always argue and try to make the textbook as the Bible. It's up to you to turn that argument around and say that, well, it is not the Bible because it's outdated in terms of its evidence and its base. And this is what is now the no. That's where professional societies can play a major role, because if the professional societies actually set out guidelines and expiry dates, then you get the backing of that particular professional society to help with these legal arguments as well.
Okay, sir. I think final question, I think, before we move on to your final part of the presentation, this is a question from me. So you have mentioned that in the CPG, there is always mention of financial disclosures of the everything, and it's very important. But this is specifically with regard to studies themselves, because we rate studies, as you mentioned, depending on the quality, and generally RCTs at the highest quality, and then as you come down with the lower quality of studies. But as you said, depending on a lot of other factors, they can be upgraded or downgraded. But does quality of the study takes into account of the industry funding of that study itself? For example, an RCT which has been funded by the industry, and that a particular what do you call, the effect has been in tune with what you expect the industry to have. Is that taken into account?
It is taken into account, and that's where the financial disclosure and the conflicts of interest come into the picture. Now, if you take a study like Copernicus, and if you look at the Copernicus study, and if you look at the authors as well as the main, I think, 8 authors, and you look at the affiliations, they're all from the industry.
Yeah.
And they're promoting the same product.
Yes.
And so when you're looking at it, you're going to look at it knowing that there can be a bias there. Now, there's 2 types of bias that come with the industry. One is that they're promoting their products. The second is that they have the money to get the best possible brains to do these things. And they can write the most wonderful sounding jargon in terms of statistical analysis, so that you look at it and then you say, okay, I have no clue what this means because I wrote it, it must be good.
Okay.
It'll be very beautifully structured in that manner, that it's very complex. Equally important, which is a big bias that comes with the industry, which is known to be a big bias, is that you can set the primary outcome measures differently. You can set your comparators differently. And hence, you can create an artificially big magnitude of effect.
Right.
And that happens quite a lot with industry-supported research. It's a known fact. It's a known piece of bias that comes in, where the magnitude of effect is artificially set because of the outcome measures that are being used. So I choose to compare this outcome with an outcome which I know will lead to a big magnitude, big show of improvement for my intervention. So those things there. So when you're looking at it, you have to be looking at all these aspects. I mentioned that you need to be looking at the data variables that are chosen. You need to be looking at the primary outcome measures that are being chosen. And that's where the financial conflicts of interest, it can be for you, it can be for your family member who is, or spouse, or someone who is a big shot in that particular industry. It can be in different way. But the point is, a conflict of interest can happen. We can't afford to throw everyone out because they're working for something. We might lose some good brains because of that. The issue is, does the guideline clearly set out how they are resolving the conflict of interest to reduce bias? And if that process is good enough, is acceptable enough, then you're on stronger ground.
All right, sir.
Kiran.
Yeah.
Mahesh here. Yeah.
Please.
No, for a tertiary level practitioner, you are a glaucoma specialist, I am doing retina. We have guidelines. For example, retina by VRSI has given guidelines, and then some study like glaucoma you mentioned. For 90% of people working in, this is, I am talking from the practitioner's point of view. 90% of people working in, you can say, not primary level. In Kerala, everyone is doing their own good work. So what they should follow in their day-to-day practice, there is no guidelines other than probably practice guidelines from the government of Kerala, which if you remember, it is there. Rajiv gave me the link yesterday. It was made 4 or 5 years back. Then it came after 2 or 3 years. Now it is
Yes.
already 5 years over, I think, when we started making that. So is it not a good idea for Kerala Society of Ophthalmic Surgeons to make a practice guidelines for everyone, that is a primary or a secondary or tertiary level? That's what I was just thinking about, because there is no this thing for how to manage a conjunctivitis, how to manage this generally.
I'm so glad that has come to this. This
Eh,
is
no,
what
no,
I
I was,
wanted.
I am a practical man. I am just thinking from a practical point of view,
This
because
is
Mahesh,
we want
yeah,
to.
yeah,
Mahesh, if that was a question to me, you stole my last slide.
I see.
I hate you.
No, no, just,
But sir, there is one
yeah.
thing I wanted to highlight. I
Yeah.
mean, this is a generally often repeated fact that, you know, most of the guidelines are guided towards the tertiary healthcare systems. I am not really sure about that.
No, I agree. The tertiary level person will manage in a tertiary level. Primary level, suppose it goes to a primary level, there are guidelines how to do direct of indirect ophthalmoscopy and refer the patient to a tertiary level if needed.
Exactly.
So
exactly.
till that time only he needs to obey the guidelines, right?
Exactly.
Yes.
Yeah. So don't worry about. I mean, even medical legally, what we should know is according to the what is that term used. That a person can manage up to one level which is competent enough.
Yes.
So beyond that it is managed by sector. So don't
Yeah.
need to make a primary level guidelines, tertiary level, it's all same.
No.
You
Yes.
have to decide till what level you can manage, how much you are competent enough. So I am just telling we should have a probably something like that. Anyway, that Dr. Praveen will be discussing towards the end, I think. So
Not discussing. I was asking. I put that question to the group actually.
okay. And that should be, there should be a probably, because Kerala Society is one of the leading societies in India, which is very systematic, and what do you, even All India Ophthalmic Society take lessons from us, in fact. So we can make a guideline in the future for taking care of all the disease, so that this has a legal validity. I am not telling
Yes.
it is because suppose one advocate takes this to the court and show this is the guideline of the issued by a authority, and you have not done that, and you have missed that. So there should be a.
Yes, I think it should come from the societies, and it should have these separate links that say that what can be done at each level and what must be
Yes.
done after that. So it can be a single guideline.
Yes.
And when it comes from the professional society, it gives great support to all the members. If there's a legal case or anything that comes there, there's a great support.
The only thing is it should not override the state government's guidelines. You know, it should not be too contradictory.
State government guidelines, Rajiv, you know how many
I know,
years
very well.
it took. but
But
now half of them
certain-
will be obsolete. Probably.
Yeah, definitely.
Half of them, Sasnam sir was there, no? Sir was very active in making the guidelines. So
But
yeah.
Rajiv, if you actually have the professional society guideline, you can take that to the state government and put it forth to them that this is the guidelines that have been developed. And
that's good.
adopt this.
It is not only, it is a continuing process. Not once you make the guideline and forget it.
Yes.
So that has to be probably revision has to be done every year.
Something?
Yeah.
Sir?
Because time and again, these guidelines, time and again, especially in specialties like ophthalmology, probably every year or every other year, you need revisions. So things keep on changing. So something which was made 5 years back, as Mahesh said, many have gone obsolete or will go obsolete. So and a forum like KSOS probably, which is very keen and active, probably, though it's a bit time consuming and needs a bit of brainstorming, I think we are capable of doing that.
Yes,
and actually in the state thing, I didn't put my head too much because I was otherwise busy. That in that guideline making, I was not that much involved for that matter. But it needs to be revised, and we should keep on revising that and updating that.
I think the initial part is going to be difficult, forming these guidelines. that may take a bit of time. And after that, it'd be easier
Yes,
to add on.
revisions.
Yeah,
changes.
actually, a
Revision.
single person need not do. A group can do it collectively, different subjects and all. You can do it actually.
We have actually got good templates already. That is very important. As I said, I've been I don't read about retinopathy these days, but I just skimmed through the Indian Institute of Public Health recommendations, which they released in 2019. I think in the version 1 of diabetic, and it's so comprehensive. It is so beautifully written. Everything is so well defined. I've not looked at retina practice for 10 to 11 years. Even I can understand clearly what I should do in each situation. It is so well documented. Yeah.
Kiran,
So
I can see Sudha glaring at you. Kiran, I can see Sudha glaring at you.
Yeah, it's
But you're not seeing retina since 11 years.
Not seeing retina, just that if there is a slight suspicion of retinopathy, I just send it over across to my retina colleague who just is about 10 meters away. So that's all.
So, Kiran, the problem is, as Mahesh said earlier, for retina, glaucoma and all, there are specific guidelines. But when you come to conjunctivitis, smaller things, which are, suppose, for a chalazion, for a lid swelling, for an injury. So for those things which small things which you think, which the common practitioner of ophthalmology comes across day in and out. Probably, as Mahesh said, for that we don't have, or we don't have really. So anything, even smaller things can land you in trouble. So what we should have is something which is comprehensive, all encompassing, rather than the specialities alone.
Yes. Right, sir. I think Dr. Praveen has also made a mention about the relevance of a particular clinical problem that should be used as a subject for guidelines. I think that's something that I think, can we, sir, move on to your final portion of the talk?
Oh, yes, we can. We can. Okay. And Dr. Lakshmi Aju, I saw your question. I saw the comment that should we not have enough multicentric studies before we do it? Lakshmi, I can now say that I feel that you have sincerely attended the workshops so that did on research mentoring. So having said that, let me see if I can move this forward to the next one. Yes. So we made the guideline. We have made the guideline. Now what? And let me plagiarize actually, and then paraphrase from Oscar Hammerstein to Sound of Music. A bell is not a bell till you ring it. A song is not a song till you sing it. Love in your heart wasn't meant to be put there to stay. Love isn't love till you give it away. They removed that bit from the song though. A guideline was not made to stay as a document. Guidelines aren't guidelines till you apply them. And that's the part that we have to take for. So usually we stop at making the guideline. And then we sort of assume that because this is made, it will be implemented. It will be applied by people. But the strategy to get that to happen, the strategy to make sure that it is applied, the strategy to make sure that there is enough buy-in into the guideline is not something that we think of as a routine. If we apply the guideline, it then has to translate into we must evaluate if it works or meets its intended purpose. Now, implementation is a process of changing practice in healthcare while utilizing the best level of evidence that is available in the published literature. There are 4 main domains that come within the construct of implementation: the practice change characteristics, the guidelines or other forms of evidence which inform the practice change, strategies to implement these changes, and the challenges or the barriers that come into as you try to implement these changes. We have several guidelines. Actually, the Guideline International Network had about more than 4,000 guidelines in 2012. And that found that the vast majority of them had never been applied. Almost never been applied. On an average, this is an interesting statistic. It takes up to 17 years for up to only 14% of published evidence to translate into practice. So that's the time it takes for evidence to translate into practice. And that's also again only a small, less than 1 in 6, 14%, 17 years. A clinical practice, we saw the example recently of the state guidelines. It is formed, it is drafted, it sits for a long period of time, revised. By the time it gets set out to practice, everything has changed and it's no longer relevant. And then you have to restart the process again. So we need a shorter time period, a shorter lag time from the development to its implementation. That means we have to start thinking about the implementation even as we are developing the guideline. We need to know what we are looking for. So we are very compartmentalized, specialized. Nowadays, we even have an expert panel for recommending change that names 73 strategies and the clear definitions, highlighting the breadth and combinations of possible implementation strategies. That's the ERIC project. And there are techniques that are meant to enhance adoption, implementation, and sustainability of a clinical program. Now, most often what happens with a program is the transition from the program to its implementation, from the guideline to its implementation, where so much of effort and energy is going into developing the guideline, while the implementation and application is left to chance, or as a random process, or as a small scale, let us say, marketing strategy. But beyond that, it's not really looked at. Implementation outcomes must include acceptability, appropriateness, cost, and the sustainability of the evidence-based intervention. So you're looking at the overall picture in terms of its acceptability, appropriateness, the cost to do it, as well as individual patient benefit risk assessments. So you need to look at both. You need to look at how is the CPG impacting on the patient? How is the CPG impacting on the healthcare statistics of the country? Sudha mentioned about fetal Doppler. We looked at fetal Doppler on the individual patient with respect to PIH, pregnancy-induced hypertension, fetal growth restriction. We looked at the fetal Doppler protocol with respect to the neonatal mortality and perinatal mortality in the areas that we were implementing this as well. So you're looking at it from two ways. The individual patient, you want to see that the risk is reduced. That risk reduction must translate into an obvious change in the healthcare statistics of the particular population. So we need to look at it from two sides. What are the attributes of implementation? You need to know what the current practice and policy is. That must be very clear, and that's what you're going to change. You need to set out what the new evidence and the new innovations are. And then you need to introduce this. You have to introduce this in 3 levels, I would say, at the policy level, a governmental level, maybe at the institutional level, hospital level, and then within that at the individual clinician. And then you have to see how it is playing out at all 3 levels. So you can have an institution deciding that we will follow this particular protocol. And you can have individual clinicians within that institute saying, but it does not match with what I believe should be done. And so I'm not going to adopt that. So there is an alignment that has to happen there with flexibility within that framework. And then there's alignment from institutions to the governments as well, with flexibility within that framework. And then you have to also involve the patient in the process where you're educating the patient about why this particular thing is better. If it's a hierarchical, patriarchal system of practicing medicine, it possibly does not matter where you tell the patient, go ahead and do this and that's it. But since we are out of that stages now, we want to discuss with the patient what are the options, why this is better. And that helps you even as you're moving around. Since we talked quite a bit about legalese, even there it helps you to build that rapport and the justification and that trust that what you're doing is appropriate. The most important aspect in implementation is the de-implementation. How do you stop doing the practices that you wanted to change? So if you're saying now that the CPG says that do A, while we are doing B all this while we are focusing on getting people to do A, we must also look at how do we stop people or get people to stop doing B. And that process also has to be looked at, whether that is happening. If that is not happening, we are ending up in a whole set of confusion with A and B running all over the place. So de-implementation is also a process that has to be looked at. So any implementation program has certain pre-existing requirements, which are known as the antecedents. They lead to consequences. Consequences can be good, can be bad. And then they provide the relationship to define benchmarks to measure the outcomes of interest. Antecedents, as we discussed, a primary care setting, secondary care setting, an individual practitioner setting, tertiary care setting. Healthcare providers in terms even of specialized units, non-specialized units, comprehensive ophthalmology, general ophthalmology, patients needing that specific care, and hence it's relevant, to develop a guideline and apply that guideline. Very important, the evidence base, and that's where Dr. Lakshmi's question about if we don't have enough evidence, should the first step be that we collect systematically high quality evidence so that we can use that to inform a clinical practice guideline. Consequences, real life consequences. You can do a guideline, not agree with the guideline, and then your practice can change because you're just completely frustrated with the whole process to a non-evidence-based practice. You're not finding meaning in that particular evidence. You're finding that the evidence is complex. It is not put to you in a simple manner. It's not put to you in a manner that is understandable. If I go and tell a primary practitioner or an individual practitioner that, well, the I2 is this and the heterogeneity is this, and I'm doing a random effect model, and now you go and do B. If they don't kick me out, they'll either beat me up or throw coffee at me. So it has to be in a manner that is understandable to them and something that they can do. And if that evidence is not packaged in a manner that someone can do, they're going to get frustrated with that because they have to do something that they don't understand, and then they'll stop doing it completely. The evidence process, if it is a lot of steps, a lot of additional work, not able to find meaning in the processes, individual fatigue of the evidence-based process can happen, and there can be a distrust of evidence and recommend. And we see that happening often, where we see a lot of clinicians come and say that, well, I'm not seeing this and I don't trust this bit of evidence. And it works both ways. I don't think we can completely discount the perception that the evidence is flawed. There is definitely a lack of communication on what the evidence means and how the evidence has been collated and the quality of the evidence as well. That can lead to increased tension between healthcare institutions and the individual clinicians. And when there's increased tension there, you're going to have poorer quality of care outcomes. And so the guideline then stops or tends to not reach its potential, moves in the other direction. And so the implementation strategies around the guideline, including educational strategies around the guideline, are important. And that must be part of the development of a CPG, which it often is not. When you do the guidelines, you're then in the process of creating benchmarks to ensure progress or to highlight incorrect or ineffective implementation strategies. So you need to be looking at all of this as you're looking at implementation. I'd sent a survey, and I think till 7:30 in the morning, there were 64% response rate. And I'm just showing you the responses of neutral response. We had agree, strongly agree, disagree, strongly disagree, and neutral. I'm looking at the neutral because the neutral is the area that is amenable to change. It can change to disagree, it can change to agree. And we can see that 36.4% of responses said that they're not sure which guideline to use. Nearly 40% said that it's not aligned to patient preference. Guidelines not up to date, 35%. They don't agree with the content, 38.9%. So cookbook medicine, 50% feel that are neutral on that. They're not saying that they disagree with the fact that the guideline is leads to cookbook medicine. They're neutral on that. So you can see that there are several elements where there is a neutrality, where there is ambiguity. You're not in favor of it is not a clear cut, I am in agreement that this is not, I'm in agreement that this is. And that group is large. That's a group that has to be worked on. That's a group that can determine if the implementation of the guidelines will work or not. And that's where the neutral option becomes important. This is the group that you need to then target and address and then work on as you start putting out the guidelines to say that, well, this is how it is and this is what it is, and then work through getting them to convert into agreement where agreement is the preferred response and disagreement where disagreement is the preferred response. So you can see that large chunk that is sitting there. Again, on those who agree, not taught clinical practice guidelines. 44.5% feel that they are not being taught or have not been taught clinical practice guidelines. Does not reflect primary or secondary care, 1 in 5. Cannot apply the guidelines to all people, 1/3, 31.5. Does not encourage thinking or adaptation, 24.1%. So what we are seeing here, I just put out some responses and based on the survey results that have come until today morning. But what we are seeing here is that the need not just to create the guideline, not just to put the guideline out, but to then look at how do we implement this so that we get the responses to the guideline moving in the manner that we intend. Again, aligned to optimizing patient care. That is an important part of any guideline. And it's a part of the guideline that is often not given enough importance, not as much importance as developing the guideline. So, because Mahesh stole my slide, he stole my thunder, if I can say my thunder. Are members of the group who are listening and members of KSOS ready to form teams that develop clinical practice guidelines for KSOS? Now, if you ask me, honestly, I think that hearing about CPG is only the first step. It's a baby step. The next step where you actually go out and start putting this into practice. And that is where a lot of this theoretical concepts come into play and then start internalizing and helps you to then adopt, adapt, and utilize CPGs even more effectively. So I think KSOS should definitely look at forming multiple teams, and it should be one that looks at what can be applied across all settings, from primary to secondary to tertiary, and in a comprehensive manner, with evidence underpinning it. We might stumble, but as Aurobindo said, by our stumbling, the world is perfected. So it's no problem to stumble. So thank you for the opportunity. I can take more questions. We can have more discussions. And I will stop sharing the screen.
Thank you, sir. Thank you, sir. So, to be honest, when you actually showed the slide of responses and neutral responses, and that 50% actually agreed to the fact that this is cookbook medicine, I'm honestly very surprised. Do you think that this is basically a reflection of an awareness of the guidelines and the contents of the guidelines, rather than, because any guidelines you read, it's hardly ever resembling anything like cookbook. I mean, the recommendation.
To put that into perspective, the neutral means that they are not agree or disagree.
Yeah.
And I am surprised that they're not disagreeing that this is cookbook medicine.
Yeah. I would expect that will strongly disagree that, it's cookbook medicine. That's what.
The second aspect is, now if you look at this very scientifically from a survey perspective, 64% response rate, a group of people who have enrolled for this, there is a selection bias, there is a response bias. So the answer may not be representative of the larger population, but I am still surprised that 50% there are not willing to commit that they are disagreeing with the fact that this is disagreeing with the statement that this is cookbook medicine. The ones who openly disagreed, fine. The ones who agreed, fine. But in the middle is a large group that is not sure what. And is that because they are not aware of what a clinical practice guideline is? Is that because they are not sure of what is written in a clinical practice guideline? Is it because they have not read a clinical practice guideline? Is it because they have not applied a clinical practice guideline? Well, the survey is not designed to
Look into that.
find that out. But what I wanted to show is that if we are taking this up, the neutral was put there to show that if we are taking this up, there is the need to work on how do we implement this. And there is a section that needs to be worked on to convert them into agreeing with where the preferred response is agreement.
All right, sir. So Dr. Manoj has another question. So he is asking, suppose you allow your individual perception to overrule a CPG at a particular instance, then are we not allowing ignorance into our clinical practice, and is it justifiable from the patient's point of view?
Well, if you are admitting that you're ignorant, then you should not use your clinical judgment in the first place.
Okay.
But if you're using your clinical judgment,
yeah, I think
you're using your clinical, yes. Sorry, Kiran, go ahead.
No, sorry, sir. I think he's actually trying to ascertain, to basically emphasize the fact that guidelines should help you in most cases, almost every case. You are allowing your own individual judgment.
Manoj is there. Let him ask.
Yeah, like Manoj, please, Manoj, go ahead and ask.
No, Dr. Nirmalan, what I wanted to bring out is that it is a well-known fact that most of we cannot be sure that of all the things that are there in the guidelines. Even amongst some of us practicing in tertiary care centers, I would like to admit that that I'm not very sure about all the guidelines that are mentioned. So there are certain things that I've taken things positively in my practice, and there are certain things that I don't practice. So when you allow this perception to overrule, now especially for people who have not read, who are not into reading publications, not into reading guidelines, will it not create a bias? And therefore now the patient, because we are going to the patient is a sufferer at the end of it. So will that not happen?
The answer to that is there are two answers to that. The first one, Manojine copy vaanchu tannal chodham choikkadirikkumo. But ask questions. I'm just joking. The second thing is that the key point there is not the ignorance. The key point there is not the guidance. The key point there is our evaluation of the outcome. And where we are missing out in reality is that our evaluation of the outcomes of any procedure that we do is not complete and is biased. If you are looking at the patients who come back to us, there are two types of patients who come. One who have improved so much that you are God. The other who has not improved, who wants to come and beat you up. In the middle is the large segment who is ambiguous, thinking, okay, let me go and get another opinion from someone else. And we miss them. So where we are really missing out, and this is a very good question. It's a question that must be asked. And thanks for that. Where we are really missing out is the evaluation of the outcome. And that's where the implementation of the guideline becomes important. Because if we have to tell this guideline worked, and if we have to convince more people, and if we have to remove ignorance, whether it's willful ignorance, whether it is not being aware of it, through whatever ways, it can be need not be a malicious ignorance. But if we want to remove that, we need to know what happened. And it's only when we know what happened with the individual patient and what happened when we implemented the guidelines that we can make that distinction. At present, if you look at it, let us look at the ophthalmic literature, the published papers. We will see a lot of papers on risk. We will see a lot of papers, not a lot, but some papers on population prevalence, magnitude. We will see interventions. We will see few papers on outcomes, long-term outcomes. We tend to say that, well, it's difficult to do. Patients don't come back. How can I follow up for 5 years? How can I follow for 3 years? I don't have. I will do it in my, and then maybe if you're in a teaching sector in the government setup, you might be having your own transfers and other things. So you don't have the luxury of being able to follow up. And so you're looking at short-term things there. But the key point to answer your question is outcomes. And unless we focus on outcomes as a key part of, at the individual level and the guideline level, we are stuck. It's a reality. It's a reality that's happening where the Practice of a guideline cannot happen because you tend to believe that what you are seeing is not in alignment with the guideline. Have you evaluated that? It need not be a formal statistical evaluation with the p-values and multiple analysis, but even on a regular basis, are you evaluating that? That means it has to translate into a very perfect or good documentation. So we move a step back. Is our documentation process good enough for us to reach that stage? So there's a lot of steps involved there. Where we tend to get stuck is at the final step where we're seeing that is nadakunnilla. And then we get stuck there. And that is where the ignorance starts coming. The ignorance is being built because we are not informing based on evidence or on data on what is happening. And we are not collecting that as well. I hope that answers your question.
Manoj, please.
Manoj. Complete this. Now, what I was thinking is, before we start putting forward guidelines, it would be nice to, look at something like a preferred practice pattern. Like in the US, they do that. So once you do this, now you get an idea what practitioners are thinking with respect to a particular condition, or how to approach a particular condition. Then when somebody looks at it, when they look at this data and compare it with established guidelines, do you know how much deviation is there from the existing guideline? And then we will be able to address this in the guidelines better. And that is what I thought.
Just to answer that, I agree with that. Now, if you look at the, I'll pull out the ultrasound guidelines, again, fetal Doppler as an example. They have the level of evidence, they have the grade of recommendation, and then they have a good clinical practice point, which might be slightly different from that, but is based not very dissimilar from. They're saying that this is a good clinical practice point when the evidence is not so much and something that you can adopt. Again, the whole process is that the guideline is dynamic. It is not a single stop. It must be evaluated, and the evidence from the field must refine it. If we don't get the evidence from the field, I would call it a dead guideline. If we get the evidence from the field and can refine it, we can actually incorporate a lot of things that are of more relevance to practitioners across settings, and then we can start working on it. But again, that has to come. We have to be more encouraging of that. We have to be motivating that to happen. We have to have a way to let that happen, encourage that, accept that there will be limitations, but accept the limitations and work with that to see how we can reduce the limitations. Then we get a body of evidence that we can take to our guideline and say, we can adapt this. This needs to be adapted, and we can adapt it this way.
Can you just explain what is the difference between preferred practice pattern and clinical practice guideline? I mean, practically.
A preferred practice pattern would be something like, if this is there, you can do ABC. If you are seeing this condition, you can do ABC. A guideline can say that if this is there, you must do this particular A only. So, Doppler, we can say that if the woman is, I'm sorry, I'm talking pregnancy. Anyway, that's our national sport, so I hope you don't mind. But if you're taking a pregnant woman and then we are looking at first trimester gestation, 11 to 13 weeks of gestation, and we say that if the mean uterine artery pulsatile T index, a fetal Doppler index is above the 95th percentile, this is what must be done. If it is between 80 to 85 percentile or 80 to 90 percentile, consider doing this. That can be a preferred practice, which most people can. If you don't have a Doppler, consider looking at a demographic history or a clinical history and consider using this, but knowing that the evidence for that is at a lower level. The basic difference is that the guideline builds almost entirely on evidence. The preferred practice can include expertise, speculative opinions, experience-based opinions as well.
Yeah, sir, I think just
so that
Preferred
Yeah,
practice patterns, Dr. Mahesh. Actually,
Other.
because the term it comes basically from the American Academy of Ophthalmology. I mean, if we are referring to that, I think the PPP in American Academy is like a full-fledged clinical practice guideline. It actually has everything, right? From the quality of evidence. They actually write it a little differently from what Dr. Praveen said about the GIN system. But
they use the IOM.
Yeah.
Or in other words, preferred practice pattern say you may do it. Clinical practice guidelines say you better do it.
Must. It is an active voice in a clinical guideline.
Yeah.
No, but
in recommendations of the American Academy, they again the quality of recommendations, they basically say two things. One is a strong recommendation, the other is a discretionary recommendation. So it's like the strong and the weak recommendations of the GIN. And similarly, the grade quality, that is also pretty much the same, slight difference. Again, good quality, moderate quality, and insufficient quality. So I mean,
for most parts, they would overlap depending on the person and the organization creating it.
Yeah,
if they're already involving and including a lot of evidence, it tends to move itself automatically into a practice guideline.
Yes.
But if they're not, and then they don't, let's say that we are doing it from an African country, a country in Africa, or even from a state within India, we don't have that evidence. And then we call the experts in that particular field and they tell that this is what is good to do. This is the preferred practice. That can be a preferred practice pattern, but it will not translate into a guideline.
Yeah. So I think with the American Academy, especially in glaucoma, it has translated into kind of guidelines because there is a lot of evidence. And
I think guideline has better legal stand than practice pattern.
In retina, there is a particular problem because in the preferred practice pattern, if you look at the data from the US, with respect to, for example, anti-VEGF therapy, there was people are favoring a treat and extend protocol. That is a new kind of protocol that has now come into vogue. Now, at the time of publishing this preferred practice pattern, there was just a single study on treat and extend which was published. So if you look at scientific evidence at that point of time, so treat and extend versus the previous regimen, there is not many studies to support treat and extend. But still, when you look at the preferred practice patterns, many people were adopting the treat and extend just after that single study. And there could also be another bias. It is possible that the cross section of ophthalmologists or the vitreoretinal surgeons that were part of the preferred practice pattern, they were actually into higher end practice, or they were part of trials, or they were part of these multi-centric trials, and that could have influenced the decision making. So there is a problem with preferred practice patterns. So the only thing is we'll understand what is the deviation from the existing literature, and probably we could address that.
Another thing is like laser in PDR. Now, if you see the evidence, now people are saying injections are better for PDR, which is not applicable in India.
Yes.
So, like lot of things are not applicable into practice.
Can I say something here?
Yeah, please.
So one thing I thought is very important is that when we are talking of clinical guidelines, it is important to understand that what we perceive as important and relevant, like what you are all talking about, like in retina, in glaucoma, these have like enormous amount of data and evidence we have, and we can, set out preferred practice patterns or even CPGs. But for an average, this is actually what I'm talking about is relating to what Dr. Nirmalan said about why a lot of people were sitting on the fence as far as CPGs are concerned, is because essentially there is a lack of trust in the whole process, especially when it comes to comprehensive ophthalmology. Like what we are thinking of as important is what is sight threatening, or probably even something which is like essentially sight threatening problems are what we think is important. But from the patient's perspective, lot of things which they think is important, like dry eye or even like a simple conjunctivitis, these are things which we do not have that kind of extensive evidence or extensive studies. And if we put it into a straitjacket of a CPG, we will not be able to practice, properly at a at a very low level, like at a when you're starting at at a primary level, it becomes difficult if you say that only you can use this kind of drops or only you can use this kind of antibiotics. That kind of takes away the independence from the individual practitioner, and that is why probably they are sitting on the fence on these, because our perception of what is important is, of course, sight-threatening problems, but from a patient's perspective and from a comprehensive ophthalmologist perspective, these are not the routine cases that they are handling every day. And definitely they'll refer all those cases to the tertiary center. But if you put it into a straitjacket, then their freedom of practicing becomes difficult. And probably I think that is why people are sitting on a fence. So what is your opinion on this?
But there is no straitjacket for conjunctivitis or the general conditions.
Exactly.
In fact, we don't have any
No,
evidence.
actually, if you put practice guidelines, it should be there for epiphora also, dry eye also,
Exactly.
and PDR also.
Yeah.
That is what Marine is telling.
That is true.
Yes.
It is
all
true.
Can I say something?
segments.
Can I say, actually, this preferred practice is not being followed by every single person in the US also.
Of course
Because,
not.
and applicability is another thing. Like, for example, amblyopia treatment study put forth that 6 hours of patching is good enough, as good as total full-time patching. So that is not applicable sometimes in our situation, because 2 hours means they may go without patching also. So this compliance and so many other things put together, not many people have completely adopted the PPP, even in the US. Applicability to their own.
Once you put these things out there on the paper, like they said, like for glaucoma, for retina and all, it is fine. But once you put it out on the paper, and then if it is difficult to follow, then it becomes a major problem, especially in legal this thing. Even if it does not have legal, like you say, sanction, you may have to face legal problems, because somebody may just take it out and say, oh, you did not follow this in this particular, this thing, and that can lead to problems.
May I?
Sorry.
See, when I was the General Secretary and Gopal was a Scientific Committee chairman, we had in fact thought of bringing out this practice guidelines. And I mean, what Dr. Marine just said is what pulled us back. See, you put some guidelines into the public domain. See, as said, see, it might not it might not help you if you say in the code that you have done this and this happened, so I should not be liable. But the opposite one is what we are worried about. See, there is a guideline that has been prescribed by the AAOs or KSOs. See, I'll give you an example. When AAOs came out with the guidelines that only 25 cases surgeries can be done in a day by a surgeon, see, it put me into trouble. So when the next guideline came, I made sure that they made it 50 cases and 25 cases in a session. See, so this is, so when there is something, and if at all, if I had done 26 cases when this guideline was in place and something untoward happened, and somebody, a lawyer comes to the court and says, okay, their association only says 25 cases and this fellow did 26 cases, and that is why this happened. So there is the worry for the general practitioner. So that's the only thing. That's the only thing that is pulling us back to really pursue this guideline. I know that it's a foolish thing.
No. Srini, probably when you put something in black and white in public domain, we should not make specific points like this. We should say cataract surgery, how to do or what to give and all. These numbers and all. For your setup, you may have 4 OTs and full-time 24-hour staff. You may be able to do. So this, when you make a guideline, this has to be very clearly taken care of.
Guidelines, you should not specify anything. For example, antibiotic. Don't write there as moxifloxacin. Appropriate antibiotic. That's enough. That's how a guideline goes. So if it is moxifloxacin, if you have mentioned there, another person used gatifloxacin, it's going to be a problem. So while planning the guidelines, make it a general statement rather than specific, like 25 number, he said. No, minimize your number so that the patients are safe. That's the word to be used in guidelines. That's what I learned when I got involved into this. So one more thing about this guidelines, let me say one more thing. What is the extent to which a general ophthalmologist can treat? For example, there was a consumer case against ophthalmologist for doing trabeculectomy, and he is not a specialist. Went to the court, he said, you are not a glaucomologist. Why did you do a trabeculectomy? See, guideline says for this you can do, but it never says you are limited to this stage only. Now, how do we handle such problems? Praveen sir.
Praveen sir, okay. Two things. One, to answer Marin and Srini and the general comment. That's why I stated in the beginning that it's important that we state that the guideline is not the Bible. We have to state that the guideline is the framework that has to be adapted based on the individual clinician. To answer Dr. Leela's comment, that is also the importance of why she has been on the wrong end of my harassment. That I keep saying that we need evidence. When we say that compliance is low, when we say that 2 hours, we need evidence to then change that guideline. Where it's getting stuck is that there is no evidence to change that guideline. And so that is standing like that. There is no evidence to say that that is not working. There is no evidence to say that that is not the ideal thing. We only have the evidence that is there, and the guideline is coming from that evidence. That contrary evidence must come. Contrary evidence must be put out. She's smiling. She's remembering all the trouble that I gave her without allowing her to sleep, messaging at 12 o'clock asking, where is your paper? And then she will say, tomorrow. Anyway. So, but we need that evidence. That again builds into what Dr. Marin is also saying, that we need that involvement and that dialogue. The guideline has to be a dialogue across practitioners. If that guideline has to be accepted, and that's where I am emphasizing on the implementation. We need that implementation strategy so that we have that dialogue built in. We understand what is needed. When we talk about relevance, it's not just a clinical problem, it's also the practitioner relevance and the problems that they face. And we are able to build all. But at the end of the day, we should not give the legal community the stick to say that this is the Bible, and if they don't follow this, hit them with it. That's our mistake. They're taking advantage of our mistake. So we have to put that out clearly. The guideline is a framework based on the best evidence. The evidence is dynamic. The guidelines will change. Guidelines have to be applied based on the individual condition of the patient, on the setting, and the individual judgment of the clinician. And like Dr. Mahesh said, we put in steps at a primary level. You can go ahead with this. We don't have to go into specifics. We definitely should not say use only moxifloxacin or things like that. Right? Again, because if I am brutally honest, we tend to overstate our positions. We end up in legal troubles. So someone says that a person, a general ophthalmologist, should not do trabeculectomy because India has got glaucoma specialty and glaucoma fellowships, and only they should do. But that's something that we are building up, isn't it? So we also have to build up the thing that there is a whole set of things that a comprehensive general ophthalmologist can do as part of their training. There are advanced steps that need fellowship support. Tomorrow, someone should not go and put a case saying that you did an indirect ophthalmoscopy. You're not a member of the Vitreoretinal Society of India. How do I trust what you do? Are you trained to do it? These protective mechanisms are something that we have to put in, and we have to make sure that it is not put in as fine print, which no one knows. It's something that we are putting out very open. So when we say guidelines, we are saying this is a framework. It's a framework with guides.
Yeah. Srini, actually, the AOS guideline is very badly made, if you say, because is there an evidence that if you do more than 25, there is a problem? As he said, there should be an evidence. So they should have attended this before making such numbers.
No. They made the guidelines from the feedback from the ophthalmologist.
But still, where is the evidence? If you do
evidence
30,
is not there. Evidence,
yeah,
that's just the
what.
feedback they have put up as.
They should not put a feed or based on
This is
feedback.
exactly
If I
what
ask,
I'm saying about
yeah,
lack
that's
of trust in guidelines and why people are sitting on the fence. Because we all know that most of this is arbitrary. None of this is, and no RCTs are done. Whatever comes, see, when COVID came, they said that after every case, you should scrub, you should take out, keep your OT closed for 20 minutes. Where did they get this 20 minutes out of it? They just plucked it out of the air and said this. So this leads to lack of trust. And so this, therefore, when you make guidelines, you have to be very, very, very clear about what you're doing and should be backed by evidence. This is all that I'm saying.
Exactly, correct. So this sort of comment should not be there.
Dr. Mahesh, the problem is...
Kiran, one small correction. Marin, when you say, when you make guidelines, actually you should say when we make guidelines. What, Marin?
Yes, that is true, sir.
Yes, thank you.
I was just saying that, I mean, we are just, let's say, fixating on an AIOS guideline, which is, as Dr. Mahesh said, pretty badly put up. And but you have so many other good guidelines in India. I mean, I'm just talking about the Asia Pacific guidelines, the IIPH guidelines on retinopathy. And if anybody has taken trouble to read through them, I mean, it is so very well defined. What are the evidences? What is the quality of the evidence? What is the strength of the recommendation? And I think we are actually fixating on poor guidelines and saying that, okay, this is so and so, so and so, when we have beautiful guidelines. I agree on the fact that you don't have guidelines for, say, chalazion or allergic conjunctivitis, but then that is basically because people might not have found it, at least the large organizations who have actually made up these guidelines might not have found it relevant for them. So if we want to make such guidelines, we will have to, first, we need evidence for the same. We need evidence.
Each word should be like you are preparing a medical legal document. Each word.
Exactly. The wording is very, very important.
Should be 25 cases is ridiculous. There is no evidence
that
for
does not make any sense at all. 25 cases
no
or
sense at
cases.
all. Srini is absolutely correct. So if we do something, we should have to be very, Srini.
No, Kiran, see, what do you say? Like, see, KSOS decides, okay, we are going to come out with guidelines. Should it be like, okay, we already have set guidelines for glaucoma. We have already guidelines for diabetic retinopathy. Okay, the KSOS endorses it. Okay, or do you want to make specific guidelines which are specific to Kerala? Then, so what I mean, you say, okay, we have a lot of guidelines which we should follow. But see, let's think about KSO's activities. And see, we decide to come out with guidelines. How should we go about it? So already guidelines are there for glaucoma, diabetic retinopathy. Okay, we endorse it. There are no guidelines for conjunctivitis, chalazion, etc. So we are going to make guidelines. Is that what you're suggesting?
I mean, if that is the problem, that actually, if the lack of specific guidelines for conditions which are less sight-threatening, as Dr. Marine said, like, say, chalazion or allergic conjunctivitis or things like that, or even your viral conjunctivitis. I mean, let's take viral conjunctivitis for that matter, which are very... And if we want to make guidelines, we actually need to have, first of all, good quality evidence on those particular conditions. And as I said, if the KSOS wants to make guidelines, we have to first review all the available evidence on these particular conditions, then arrange those evidences in terms of the qualities mentioned, and then make recommendations. That's a very, what do you call, as I mean, the whole process Dr. Praveen mentioned, it's a very detailed, intensive, long process.
What Dr. Praveen has already pointed out, reaching a consensus has to go through all these steps.
Yes,
and it makes sense.
That is perfectly possible.
And we need that,
it is not for just a few people to decide that we make the guidelines. It should be, first thing is to make the general public aware that there are guidelines. This is what we are trying to do first. It should be there in KJO, it should be there in your CMEs, that there are things like this. So first let them become aware, then only they can make out that these guidelines are working or not, or whether the need for changing comes or not. Right now, is aware. So the first
Yeah.
thing that we should do is make it aware, make people aware that yes, these are guidelines and these are good or bad is for you to decide.
Madam, that is
Srini
precisely the
was
point,
telling it is available in Glaucoma Society, Retina Society, like that. A general person may not have all this.
Yes.
Even we can do a good compilation and give it to all our
Yes.
members so that they
Yes.
can practice.
Absolutely,
We are not going to
Exactly.
create anything. So it will be a, I know
Exactly.
there is a
That's-
DRCR net and glaucoma, this thing and all, but when we practice, everything is not there in my hand. So I think
Yeah,
it will be
we can
useful.
actually come out with a book which contains all the available guidelines, which can be circulated or compile everything. Need not be a hard copy. It can be soft copy. Which can be, so these are the guidelines. These are the guidelines. These are the guidelines, and probably that would be a good idea. And work on it. Start with that and work on it. Like let's collect, as Dr. Sudha said. Let's get the opinion of.
Can I say something?
Yeah.
See, Kerala government has come out with the guidelines. It is there in the site. So it is our duty as a society to make changes, whatever is needed, which we think it's going to be dangerous for us, and represent us in the government so that guidelines becomes very strong.
That is
Instead
where
of me
advocacy by
coming
KJO-Scientific
out with the
extremely
guidelines and
important.
circulating, it's got no value at all. When a governmental organization comes out with the guidelines, it's got its own value. Now, what we have to do is, some of us should go through those guidelines, which is there in the site, find out what are the flaws in it, try to correct it with evidence-based, as Kiran said. We'll do it, give it in writing to the concerned person. It goes through RIO only. It goes through RIO only. The director is in charge of this. So once this process, once a year they do it, updating, we'll help them out with the present and try to include all the topics which are not included in there. I think only 4 or 5 topics are there in that. We need to include others, but let's be general, not specific. You should do, those words should be avoided. Yeah, things like that. The appropriate words should be included, like legal terms should not be used against us. So if few of us join together, we can do it. It is good for our society. It's definitely good for us. And this is the first time in the history of KSOs we are having a webinar or even a conference on CPG. And I should congratulate Sudha for that. She's taken a very good initiative, and this is going to help all of us in the society.
Dr. Praveen, before I let go of you, just one quick question, please. This is slightly a technical question because this is not something that we get to ask very often. You see, there are, you mentioned about the differences between systemic review and meta-analysis. So in meta-analysis, you come across Cochrane very often, the Cochrane meta-analysis. So does the Cochrane group uses a different methodology, somehow different statistical methodology for their meta-analysis that is different from what is used by, say, other groups?
Cochrane comes from the name of the person, Cochrane, who actually worked a lot on meta-analysis. They use their own specific software, the Revman software for it, but the statistical testing is the same. You can use the Revman software for doing the Q-test, heterogeneity tests, and all those things. You can use Stata for that. Stata is a statistical software. I think you can do it even in SPSS. You can do it in SPSS also. So the analysis pattern doesn't change. Okay. But that was a group that was focused almost entirely on systematic reviews and meta-analysis. Okay. And so because they were focused almost entirely on it, we sort of gave them the honorary position of being knowledgeable or the most knowledgeable on that particular area, because they're focused almost entirely on that. And so the depth of knowledge is more in that, and they get more data, and they then get to test out different statistical testing and things like that. So the meta-analysis tests are statistically can be applied. Cochrane has put out what can be done and what need not be done and all those things. The testing is same. There's no specific Cochrane test.
Okay, my question was essentially, let's give an example from a practice perspective. Let us say we are comparing two treatment modalities A and B. So the Cochrane group has published the meta-analysis of A and B, and you will be having a couple of other meta-analysis from other institutions in the world. And suppose they are slightly different, and let us say if the Cochrane meta-analysis was showing that the difference between A and B is not really statistically significant, but it is showing, say, a trend that favors A over B. But the other groups are clearly saying that okay, A is better than B. So what I meant to say is, as a lay practitioner who doesn't understand statistics so much, would I give greater emphasis on the Cochrane group's study?
I get that. So what usually happens is that we tend to give greater emphasis on the Cochrane study because that has got the name. But what is really to be done is that you make your individual analysis of what is appropriate. So you have to be looking at each group, the other two groups as well. As well as a Cochrane. Cochrane can make a mistake. They are humans. At the end of the day, they are humans, and there will be a subjective element coming within that objective process. There can be a mistake. It again depends on the underlying studies that are being used for that particular meta-analysis. Okay. Now, if the underlying studies that are being used for the newer bits of evidence is recent, better studies, then you can't say that I would rely on the Cochrane evidence alone. No. A real life example, again, I'm sorry, I bring it back to pregnancy. A real life example comes in the algorithms and the evidence that is used for the early identification of women at risk for preeclampsia. Okay. The NICE guidelines and the American Academy uses a clinical history plus demographic history guideline. Okay. And they say that we can identify so many people. Fetal Medicine Foundation then looked at all the fetal Doppler parameters and they collected over more than 1 lakh. 2 lakhs, 3 lakhs of bits of data. And then they came up with an algorithm that is statistically well compiled. And they're updating it in real time, keeping on collecting data based on ethnicity, and they're modifying and refining that. Now, when the fetal medicine guideline came out, again, the question was, it's an independent group led by a person, and then researchers interested in that. Do I rely on that? Do I rely on the KJO guidelines? Do I rely on the NICE guidelines? And things like that. So people generally, when we talk to obstetricians, the greatest barrier for us was them telling that KJO says this, NICE says this. Fetal medicine says that, but this is not what they say. So we don't tend to apply that. And then we had to come with evidence to show that it is changing. And then evidence had to come from India. And so we had studies from Lucknow and other places coming, showing that there is this change. And then slowly it started. But even then, the adoption became better only when the National Federation, the FIJO and the FOXI decided that we can now use these guidelines. So the change, which one to apply, brings me back to the favorite point that I keep hammering in, that we are not actually teaching our students how to read a paper. And when we are not teaching them how to read a paper, when they're going out into practice, this is the problem that they face. And then they have to, it's a pragmatic reality. They have to rely on the reputation of the institute or the author or the person and believe that that might be true. Okay. While it may or may not be true. And there we tend to lose a lot of evidence. So this bit of it where we teach people actually to read the paper, to understand the evidence, to critically look at it, and then to see that when we are looking at a paper, we are not looking at the person. We like the person, don't like the person becomes insignificant. We are looking at just the bit of evidence. And if that is matching or not matching, appropriate or not appropriate. If that can be taught, then a lot of the work that needs to come in actually starts reducing, because you're getting an evidence literate people coming up, and they will be willing to share their data and help you refine the guidelines as well.
All right. Okay.
Excuse me, may I share a thought here before we discuss? Just one thought.
Sure.
Latika, sorry, should we disperse after you share your thought, or we can sit for some more time?
I mean, that would be a pressure, but still, maybe shall I say something regarding the implementation? This is regarding the implementation of CPG from a KSOS perspective. So I was, whatever the guideline we are talking about, whether it is a updated Kerala guideline, which would be the ideal one, or whether an APAO guideline or an AIOS guideline or IIPH guideline, whatever guideline it is that we are going to adopt and KSOS is going to endorse, that is one aspect of it. But the problem is, the real problem is one of percolation to practitioners, and that is where KSOS should come up with new ideas to get it into the actually into the practitioner's head. So what Srini was just now saying, that we should come up with a book of all the guidelines we should compile and then distribute among KSOS members. That is a good idea. But what I feel is that for this guideline and CPGs to actually work out, there should be a lot of give and take between the practitioners and between the group that is actually working on these guidelines and trying to implement them. And if that give and take is actually should happen, then it should not be a centralized process. It should be a decentralized process, and that can come only by the active involvement of the clubs. And these should not be books, big books, but these should be small pamphlets or laminated sort of things that each member should be able to access, or the clubs should make sure that they are all there, they are all reaching their destinations, which are each individual members of KSOS. So books may not be enough for that. So this is one perspective we can think about, decentralization of this entire process and implementing it through the clubs, through the various groups. That's all I wanted to say.
Latika, why do you want to only implement it through the clubs? Why don't you involve the clubs in the development?
I said two-way, not only implementation of the guidelines, but the collection of the data, the facilitation of research for the interested practitioners, all these. That is two-way. That means
as well as increasing the awareness.
Yes.
And Latika, I think you should seriously consider the option of giving speeches in Parliament also.
you really have to pull my leg.
You want to say something, sir?
Rajeev, before you wind up now, one thing I wanted to say is, I'm not very sure how much the Kerala government document is comprehensive about. So if you do one, taking into what is there, and we modify it, update it, make additions, I don't think if KSOS as a society, this is a good job, I don't think there will be any problem with the government endorsing it. So we'll have to go through that process, but I don't think it's going to be a big problem. So the existing one, I do not know whether it takes care of all the things. So we can also, as discussed earlier, we can, whatever the glaucoma, BRSA, and established AOS guidelines are there, we need not go into contradictions and go into duplications. So whether we want to update anything on those, or tailor made something which we have to make. So we have depend on that. And on the case, this Kerala state guidelines as it exists today, whatever modifications we make as a society with good thinking going behind that. So I don't think there will be a problem with the government endorsing that, though it has to go through that process as you said.
Channel.
Yes.
Thank you, sir. Mahadev, sir, anything to say? Sir?
Muted on.
So if there are no more questions, we can, Kiran can summarize.
It's been an absolute pleasure actually listening to Dr. Praveen talking about the various aspects of clinical practice guidelines. I'm sure we all of us learned a lot, and and he has also put in certain buts that we should probably carry it forward in the future, and that would probably be his main inclination. And I completely respect his passion. Just so much, it is so clearly obvious when he makes the presentation how passionate he is about all these matters. And it is so we are very lucky to have him with us on this particular day. And we are hopeful that we will continue our association with you, sir, in the future as well, as we go into the next steps of what you described today. And Dr. Sudha would probably want to conclude the session.
Let President say a few words before Dr. Sudha concludes.
Dear friends, it is a very useful, wonderful talk and discussion. Thank you, Praveen, for enlightening us on these things. We are looking to the matters of forming a guideline on behalf of KSOS, thinking or taking all the matters into consideration. So that is actually proven she can do so many things. And thank you, Kiran, for that better comparing.
Thank you.
Mahesh, anything to say?
I have already told too many things. We should seriously think about it, at least for compiling, not making, compiling the available data and modifying the data to suit our members and making the data reach the member by, as a society, going through proper channel. Thank you.
We'll put it up in the website. Yes, Sudha.
Okay. This whole purpose was to start a dialogue, and it has been really gratifying to know that it has occurred. People have really attended in good numbers. We were expecting 10 or 20, but actually registered was 90 people. And that's a huge number. Many of them attended. Okay, fine. They have become aware of it. Many of them actively participated. We still have a good number left at the end of it. So very nice program. And I hope this continues, this dialogue continues. And Dr. Praveen remains here for helping us out with this. And thank you everybody for joining. Thank you.
Thank you.
Okay. Rajiv?
Yes, Parnolo.
Marine unda, Marine? Marine poya? Poya? Marine poya. Korbula, just Marine
multi-centric studies in the